you found an experience in green light Xenon treatment of and there's also focus on radiology and there's also developed good practice in the system itself in terms of like.
Yes, let's focus on the atmosphere. Thank you. طيب تحبوا نتكلم انجلش ولا ميكس اوف عربي and English which is more good. Let's go first. طيب suppose يعني let's start with the green light first. Green light انا always call اللي هو الايه black horse. اللي هو it suits everyone, it matches everything, and it's easy, it's safe, يعني it's good, and it's hiding from the community community مش عارف ليه. I think the problem kind of that experience in the past مع ال 80 هو old KTV وال 120 اللي هو HPS system. لكن صراحه حصل development جامده قوي لما حصل. فاعتقد ان this is the problem. Now if it's very bad experience and it was a very slow system in 80 وال 120 مع XPS it was a big difference. هقول لك حاجه لطيفه جدا. انا لما started in the UK كان ال 120s there and they were very excited about it. But on my arrival in Germany اللي هو February Park الكلام ده في 2010 يمكن لا اسف 12 13 والارقامز بتاع كان الجروب ستادي كانت لسه بتبتدي والكتب بتاعه كان بيشتغل في فريندلي كان هو اللي هو الكلاين سنترز و kind of was involved in my life from the beginning. واول ما ابتديت اشتغل في الاكسبيرينس I never used anything else. وكان Neil Barber كان using lots of يعني he was doing green light laser for ages. With 120 he was kind of happy with. I think هو having a big advance. We could use the 180 and he was very excited. And I remember quite well هو كان في زمان فاكرين الفيديو جيمز بتاعت كان اسمه ايه؟ حد فاكر اللي هو ايوه هو الكلام ده كان هو ده الاكسبريشن اللي قال يعني قال اتس لايك it eats the frosted rather اللي هو الاولد اتش اللي هو 120 كان فيري سيف بس كان ليك ماكسيمم بعد 70 جرام يعني يجيب بولت انما ال 180 ده كان مكنه زي ما بيقولوا.
بس ما عندي اكسبيرينس يعني انا كيف الشغل اللي سوى ما عمري سنت
في جرين لايت هو عشان الكاد باك ريبيتيشن يعني سوري اتس ويست اوف تايم
سوري اتس ويست اوف تايم تتعلم بولد وتتعلم شيء صح كويس وتتعلم شيء صح
اتس كومبليت ويست اوف تايم which is the 81 ال 180 is a different story الحاجتين الحاجه الاولانيه الباور اعلى كتير جدا الحاجه الثانيه الفايبر قبل كده الفايبر اللي هو 120 والفيري سمول فايبر محاولة الموكسي فايبر was much bigger والرينج اللي بيشتغل فيه اكبر فالاكشن فالكواليزيشن اريا is much bigger السيفتي بقى superior لان انت بتعمل فالكواليزيشن 1 to 2 ملم والفيري it's not correct it's not correlation بس الفيري مستحيل يريد don't worry about it خلاص ما بتشوفش يعني you can't see that we can end up with some bleeding in some cases absolutely fine but very unlikely. The good thing about it برضه ان هو it's an easy gentle learning curve and you can't start with gentle learning curve for vaporization. حاجه اسمها vaporization and you can stop doing by doing vaporization it's almost an application بس يعني in a controlled way. Or you can step up اللي هو proper application of green light. فانت you can end up doing an application بس you don't need بقى ان انت to worry about taking the 50 or 100 pace of the whole trip. We don't need to worry about the bleeding risk is less. عشان high power you can control coupling. الهولد بيديبند mainly على pushing او الهولد application. فالريسك حتى بتاع الكونتنتس والكلام ده يعني ف this is what is good about green which is green ان انت you don't start learning you start by vaporization وبعدين this journey ان انت صار انت after 10 cases you're very comfortable to do any case of green light. After 50 cases هو evaluation. After 100 cases you can do evaluation بس مشكلة evaluation انت you have to have other so you have to invest in different equipment او بعد سنة فهو the kind of natural pathway to evaluation. في نفس الوقت عندك one technology that you can use it for more
فهي اللي هي ستيب باي ستيب اللي كان move on and on and on. طبعا الترخيص بتاعها اللي هو الكي تي بي والاذر كان والرينج بتاعها 5 to 5 وده اهم حاجه اللي هو الروبس الووتر ميديم الروبس مثلا and it's attracted by it's green because attracted by the color عشان كده it's very hemostatic. الهيستوري طبعا بتاع الليزر الابليشن الليزر بعد الدياك مشكله الدياك ممكن تبقى فالفلتريشن كويس اكسس ديما بروبلم سلافينج بروبلم ديسيوريا الهيستوري بتاع الابليشن بتاع الليزر كان باد فعشان كده كل ده كملنا يعني ما اعرفش لو اصل دي مش انت بتاخد الاكسبيرينس بتاعتك من someone else ده لو كنت بتكلم عليه قلت له ده يعني وده دياك نط منه جرين لايت ليزر دخلوا جرين لايت النهارده انا فاكر جرين لايت دوت انا بالتالي كان بشتغل شويه في مصر فكنت لسه التبيكي ده جاي ده في مستشفى اللي هي بتاعت المركز الدولي للمسائل والصناعه وthey're very excited about it مش عارف ايه very مستهلك بتاع بس شويه they walked it back للتي ار بي it was too boring they said still the same like you should do that channel that it was a very big problem this is how we have that application بس الصراحه there was a big jobs out there that الانتياج it's legal ومشكله it's coagulation power كبير جدا with lots of edema lots of stuffing فدايما كان كمان الستوري كان بتاع الديسيوري وانا فاكر كويس قوي ما ابتدوا برضه في الاكسبريس some bottle on the other side who is the killer this is nonsense. أنا فاكر حتى اللي هو الديسيوري have this conflict. أنا الصراحة it's very powerful. أنا هو ده this is the only thing I used XPS. حتى يعني I don't know how much I done transfer the perspective more than I've done TRP and obviously the massive number I've done is green light and discipline. ليه؟ لأن this is how I really came. فأنا عارف ال TRP is a really good operation. There's a problem. It's kind of risks. People die. People do something. I never had a problem. Not like any health issues possibly like this. How to live in this. فبدأت كويس قوي مع الانتياج بس الإديمة maximum edema lots of coagulation lots of stuffing it's an uncomfortable situation. The green light that only do to maximum of 2 milliliters. فبدأت this problem it's vaporization of coagulation. The patient disappeared completely بس in a controlled way. الهرمون دي برضه why it's not good ان هو الهرمون is quite فالانكليشن is very good. فانت بتعمل كده في الممكن push coagulation and then coagulation push and coagulation. It's not vaporization. And they try to use it as vaporization before. والفكره vaporization actually is the irrigation don't need a plane anything you just throw it to the and you just وبالتالي ملوش بوست 60 جرام سايز في بس الريجن طبعا is perfect يعني we don't see any problem with retention especially لما يكون عندك عندك retention لما يكون chronic retention لما يكون 1 لتر inside you want to create a big cavity علشان تقلل الريتنشن هي الفكره كلها ليه الانكليشن is very successful because we remove about 60% of the volume produced
compare the PRP 40-60%, create line 40-50%, resume 20%. فانت when you create a bigger hole, the pressure, the interest pressure will be much less. حتى لو انت عندك proposal failure or knee failure, most likely you match. عشان كده الهوم implantation is very successful for this reason. بس في العادي the very large positive chronic potential outcomes. We couldn't do vaccine. The learning curve is important. It's an effort procedure. The resistance level proliferation. أكيد ما فيش حد بيشتغل عمر احكي لنا قصة بتوعك. سمعك. قول لنا قصة المقاسي بتاعت الهوم. في مقاسي في الهوم. ها؟ ممكن. ايزي. ايزي.
انت اوبريتيف
it's not uncommon بس احنا وبعدين يا سلام انت جنب اليوتر. Well, usually after once انت دايما ايه you're under tension as a surgeon. It's not relaxing.
المشكله مع الاصلاح مرات ما تعرف انت وين صرت
especially the big hospital which is most of the hospitals. فهي وبعدين حال يبي كونفليكت او ليست تيست بس you can't end up with problem. Plus how the more motivation is back on first تدور على اخبار الستيس
الكونتنتس
how the percentage
اقل من تراب
اعلى طبعا 100% there is no way that will go. فدي حاجات برضه يعني بتسفل there is no technique at the same time. هو ايه دلوقتي؟ فطبعا it doesn't come without risk or problem. It is مفيش عيب بيروح نفسه. يعني في ناس كتير قال لك الهوليدي can go the same way. I doubt. How do you count it? They go home less than 23 hours. And this is what they call a day case. يعني العيال بيخش الساعة مثلا 4 العصر مثلا عمليات ويروح تاني يوم الساعة 3 العصر. And this is the day case. So that's what this is how they play it. I remember we've seen how people can manipulate it that. So in reality, يعني one or two nights. It's not more. And when this clinic is very good machine, but it's not brilliant. There is fumation and camping, and there is blood transfusion. صح. It's good. I'm not against the home at all. بالعكس, it's very good, but also it's not the perfect one. ايه كاركترستيك بقى في الكلين ليزر ان هو الفري ترانسميتد يو دونت لوز انرجي في الريجيشن ودي حاجه بتحصل عليها كتير قوي عشان كده يعني you need to be close to the tissues but ده سبب اخر ليس ان انت it's not because you're losing energy because of the arrogant irrigation or the salami or the root or whatever بس because the closer you are you get a concentrated beam with a higher power so you get better polarization. And selectively absorbed by organ عشان كده الهيموستاتيك يعني it is the safest technology that we can ever use in patients who have coagulation. أحسن حتى يعني the resume is good as well الحاجات التانية دي is absolutely fine but if we compare it to cavitating surgery because this is the cavitating category of surgery. And the cavitating surgery هو surgery or the resume that you have to cut. This is not a cavitating surgery. I'm here to for soft tissue removal things. يعني soft coagulation to the person وده very important. You don't want to have to lose control. If you want to deal with a small prostate or a big prostate, so you want something that is causing polarization more than 1-2 millimeters. But for us, we find certain young capsule, and corruption once you cross the capsule, this is when open sciences vision will be more perfect, life will be better. طبعا this is very important. ساعات بتخليها يمكن slower شوية and make the teeth down the bigger prostate. It's okay, it's safe. You have to be patient.
small optical penetration gives the tissue. We talk about this high power density. Now density بتاع البار that's why you have to close it the tissue عشان تجيب high power density. Visualization is very efficient, very efficient. The first rate of visualization is possible with high power at 180. You can't start from the beginning as 180, but usually I start with 80 علشان اللي هم the lower power is more active, the higher power is more surprising. فحتى اللي هو الcoagulation mode of the green light is a low power interrupted. والvaporization power it's a high power and uninterrupted. فهو high power is a vaporization power بس انت دايما في اي بوست بتخش هتلاقي البوست كبيره وتجستد some varices دايما بتستارت من 80 to 20 and then once you come from there is no visual signs go up to 180 هتلاقي صاروخ ماشي معاك. efficient implementation دي هنتكلم على البلاد ستادي وانها did the same outcome and we didn't have any problems. There is no inferiority. It's not inferiority study. It's a similar efficacy as TR, but much similar. We needed symptom advantage. Coming back to this, is اللي بوصل ليها وده نتيجه ان ما عندكش coagulation. Coagulation هو اللي بيعمل that's why you don't have stuffing. نرجع للقصه بتاعت سامو بارت. سامو بارت كان بيقول لي مع دول كان بيجيب اتليزم كان بيشتغل very uncomfortable for a few weeks after. But I was insisting that I do patient just to see other nurses would see or he may not even come if everything is fine. Telephone consultation by nurse or class. How will he see by some another level? I insisted for at least 100 patients to see them. The findings are they discomfort lab, the least painful procedure. There's nothing stool. في بيحصل stuffing مش بيبقى طبعا مش وساعات after 10 15 days كده ولا حاجه possible blood clot اللي هو حته كده snuff. This is true. It happens. We wonder about this, but it's not massive. It's not. The dysuria is very big. So the dysuria story is الديسيولا بتحصل من excessive coagulation. ولو كنت حاسس شكل تعرف حاسس شكل ولا لا؟ حاسس شكل مش هتعرف مش هتعرف vaporization. مشكلته هنا ان عايزين very uncomfortable post procedure عشان الcoagulation بتاعت is very high. فابتدى يعمل ايه بقى؟ بعد ما خلص الفيزا والبوك كيرتي يجيب اتش دي ار يشيل الايه كل الكواجيليتيف سناب ده فالعيان عشان بتصير. Which makes sense. هو المشكله في الكواجيليتيف بتيجي من الكواجيليشن والبلاك تيشو. بدون البلاك تيشو it's all white tissue. فالانسس اوف الديسيولا ده is ايه؟ is history. It's not true. The best the best. يعني انت الكيو ار يعني الريجيشن يدوس يا معلم وبتاع وقف وتقف كواجيليشن تقف كواجيليشن تقف كواجيليشن. يعني you can this can happen sometimes with the blood if you open signs. والصراحه what I do now is something like for bleeding what I do is to completely this area and move to another area start the region from different place. دايما البليدنج مثلا في الساعه 11 واحده كنا صايرين الوسط دايما فيري ثين. فديس ذا ايزيست اند ذيس وير از ذا دوز كومبلكس. فلو اشتغلت هنا زياده شويه مش كده لو في هنا ولا صح احنا ما بنطلعش كده. ليه؟ تخيل ده البوست عامله كده هنا اعمل زي ما انت عايز تجيبه بوست تيشو هنا فيري ثين بوست تيشو اللي هو غير البوست. ففيري ايزي it happened. Go down, go this area, because it will stop by itself. And start doing somewhere else, go to the other room, finish your operation, and most likely, by the time you come back, this will disappear. But if you concentrate on the same area that bleeds, and I want to stop it, وبعد كده ايه بقى؟ واطلع تاني وهعمل بلد وبتاع تطلع على سيرتوسكوب وهعمل sometimes if you had a bleed في البلد لو انت يعني unlucky ويعني you can't go price of the same. بس by time after
understand where to avoid and how to. Again, extremely blood procedure, you can easily in general, if you can stop anticoagulation, stop it. يعني هي المشكله ما بتحصلش ساعه الاوبريشن. الريسك بتاع الدبل انتيكوagulation فلا في في اسبل محدش عارف في اسبل ده بقى هو الورفس الكلافيكس الحاجات دي كلها لا الورك وز سبستيفايد بس الكومباينيشن هو الثيرابي يعني مش كل يعني ناس كتير كانت موجود هناك بالذات عيد السنه الاولى الاوردر مش الصراحه يعني قاعدين التمرينات اللي طالع فيه يعني لازم فانت محتاج حاجه زي كده مش محتاج قاعد كمان مستشفى احسن من الوظيفه بص أنا مش فاهم يعني شوية واحد هو بتاع 30 سنة وصلنا ده على ولا علينا لا هو بوظت لنا الداتا actually تقطع شويه بص انا حاطط فيه بتلاقي مش جاي مش مقطع obviously it will benefit from motivation, so this saves time and then so I said that all kinds of أنا أعتقد 60 next year اللي هو التكنولوجي اللي هو بقى لي فترة بس مش تشترك مين معلش اشترك بص اشترك قبل كده دي اس صح ايه بس هم It's very hard. عشان كده انا اعتقد المشكله الثانيه ان هم واعتقد ان دايما هو الفيجن بتاع so it's a problem. It had a bad reputation. بس انا بقول ان الرسول اول ما طلع كل الناس قال لك مش ده زيه زي التونه بتاعت سنه كده فيحس مش اول ما يلا كل بتاع ده يعني غريب او ممكن actually this database. This will tell you the green light is safety.
flexibility for what you can do كل الكلام ده. It is في courses بعض الcourses بتاعت general function integration fertility upper construction صراحة ما بقلقش ان انا اعمل بس ببقى I want that الآلية الصناعة تاخد وقت وبالفعل الابلكيشن تكنيك او الاناتوميكال اورجنايزيشن او it doesn't take time. It's not smart. Radiation therapy, you have to be careful anyhow, but it's not radiation therapy. ده ليه 150 فكرة بحس ان انا يعني اخش على radiation المفروض انت لو انت if you are comfortable with radiation and you have more cerebral انا بحاول بس في حاجه هو وفي بعض مش يعني بص يعني it's one hour يعني still one hour more بقى من كده يعني more than 150 this is when you it takes about longer time and you kind of the different low blood pressure وعايز some sort of لا ولا التايم حتى انا اليوم هو التايم بالنسبه لي هيت وورك يعني after 1 hour of organization you get bored الصراحه يعني بس by the way يعني big labs from corporate takes 2 or 3 hours مش كده ولا ايه؟ فايتس ستيل برضه it's not easy يعني بس هي النقطه ان انت قادر تدير الاتنشن proper attention or يسلم في الاتنشن تدوس بسبب ان build that information that you really need to remove more pressure. The organization will not effectively go more than 40%. Oh, sorry, more than 40-50%. بس خد بالك 40-50% البروستات 70 جرام بنزلها 30 وغالبا ال 70 هتقدر توصل فيها 60%. بروستات 150 هتنزل التمرين او 90 مش هتقدر هو مشكلتها كمان هو he will keep but the risk of recurrence بالظبط الريجروث هيبقى عالي وده بيحصل اللي هو الايكوال فيبرايزيشن يعني انت بتفبرايز one side very good the other side is not as good because of many reasons because you want to finish with another patient afterwards it looks fine now عشان الثانيه بتديك الامبريشن ان it's a big cavity now this doesn't فايت's not بس لو عملتها بالفلاب تكنيك it will be fine but برضه زي ما الليميت بتاعك مش هتروح بالنمبر 150 let's say 65 you can go to 180 that's fine you can go to 200 if you want لو العيان عايز على هاي ريسك بقى على انتي كلام من ده هتستقبل وساعات في ناس بتعمل حاجه ثانيه they give them for this time for a while and they bring them back downsize it ويشتغلوا وفي بيبر قالت ان مفيش فايده للفلاشلايت بيفور وافتر بس مش بالفيجن الفيجن بتاعت الفلاشلايت ان هو كان في ناس بتدي الفلاشلايت لا الكلام ده اسمه بس برضه بيقولوا لو اديت فلاشلايت بوست اوبتيكلي بتقلل النيد فور البيشنت تو كم باك تو سكند اوبريشن برضه عشان كده في البيبر ها العين اللي هو you know that it's 140 يعني 150 or 160 but we still say anything outside الصراحه طب خلينا نيجي للنقطه دي هوريها لك بص على اصل انت if you go and feel that it's a smallish post يعني اقل من 50
فابرايزيشن از ذا سيم. البيجر بروستيت الشيك بتاعها بيفورس يو ان انت تخش في المشاكل. ايوه شايف اللي هو حاجه يعني كان بس يعني ايه السمول سايز از ماتش ايزي تو فابرايز، مش هيبقى في ديفرنس، فيو نيد تو جو اب اند داون لازم تفنش كويكلي ignore time to finish. Precautions for work antibiotics. تبدا antibiotics في كل حاجه صح؟ مش كده؟ definitely. Yes. I strongly recommend one patient with bad infection will teach you very polite. I had a very interesting case. We had antibiotics, بس مش كل يعني ساعات بندور antibiotics هو يبقى high risk patient دكاتره. فالحمد لله العيال اللي مثلا high risk دكاتره I give them gentamicin and countermicin. اللو كافتا gentamicin insufficient. بس هو النقطه في انا فاكر عندها he ended up with optical infection. It was horrible. He was about to lose his vision. Injection in the eye. فاللي هو يعني there's no games for that. Catheter dependent patient beforehand. دايما الكاثيتر dependent patient are very cautious because we pass ولا حاجه يعني if he's symptomatically infected start antibiotic beforehand. Okay. If he's هم كلهم بيبقى عندهم ميكس كروس خلاص، بس لو he's symptomatic give treatment beforehand. ده العيان بيقول لك انا عندي انفكشن فبيبقى عنده كاثيتر سيمبتوم بتبقى زياده سميلي ستيربل all this لا بالظبط كده. فانا عندي دي ده في البي اسسمنت لما بيكون المنظر ده البي اسسمنت ده عندنا ريست يعني ما تيجي وبدي اولويز اسكس عنده ميكس كروس ولا هيكتور كاثيتر سيمبتوماتيك ولا سيمبتوماتيك اسيمبتوماتيك لا اتس فاين بس اون ذا داي او جيف كومبينيشن جنتامايسين او if he's allergic هدي تاك فلا البوست في حاجه العام يقول اصلا I don't tend to always give post operative بدي بس الفلاكي دو سيمتوم. احنا اتكلمنا بقى عن انتي كوagulation لو سيف انك توقف الانتي كوagulation وقف لو مش سيف الانستيزيا يعني بص انا ما بسمعش عن حد بيعمل ليزر سيرجري وده انستيزيا بس انا مش شفت بس يعني it's important واعتقد ان شانل هيكلمنا عن الموضوع ده هو he can do TRP السويد دول ناس جنب يستحملوا ايوه this is true البيك threshold بتاع الويسترن والوايت بيبل is much higher than the eastern ويعني احنا بنعمل a lot of diagnostic systems anyway ولا شيء بص انا عارف اول ما يجي ايسترن ده مش ميدل ايست او فار ايست يعني الجماعه برضه الهنود وباكستان برضه عارف انه بص يعني الفاكسين بتاعها it's a cultural thing دي حاجه واعتقد ان البنسيشن اعتقد ان هم اللي في الكود ويذر بيهاف هاير بنسيشن وبرضه اتس ذا سيم ثينج احنا بنروح هناك ما بنستحملش الساعه هم ده with the t-shirt they have a higher penetration صعب يعني kind of nature pursuit البلاكنس black people also are very sensitive to this فاعتقد ان هو that's why يعني اصلا انا فاكر ان احنا عملنا ماجازين جاب راجل اسمه كان برضه سويدش all his limit جاب all his issues is done systemic هو إذا retired ومش it was just local we're doing a table discussion You're welcome to join.
Yeah.
بس
أنا طالب من مستشفى الأهلات.
أهلا وسهلا. Now we do discussion, we decided to start with the green light list. Trying to convince people that green light is something that we need to serve again in practice. So we talked about the safety. It's very safe. You can use it for double application. It's fine. You can move on from vaporization to atomic vaporization to occlusion. The learning curve is you learn alone. You learn at the same time to treat patients, which is not the same as evacuation techniques, that you have to take long time to each stage of really treating patients, and you have to have long time of supervision. That's if in green light, you learn vaporization, and eventually it's intuitive and you need to take it to the evacuation technique. Nobody should be doing evacuation ولا تعلم evacuation, but eventually after 100 days of vaporization treating patients, دخلت about 15 cases على standard of school and vaporization, and now I do some evacuation aside because I don't have oximeter. I still leave it on a stack and either vaporize it or sometimes it. But if you have so it's kind of it's a growing learning curve that improves with time, and you can teach yourself a new technique learn and go and be taught a technique. السيستم اللي بنستخدمه في الهوم بنستخدم وولف مش كده وولف. يعني بنستخدم سيكتوسكوب في تو ثينجز. كان في الاول عندنا هو الستورز. الستورز كان 22 بريدج ليزر سبيسيفيك ليزر شانل ب 30 ديجري تلسكوب. وبعد كده البروبلم في الهواء في الستورز ليزر سكوب اللي هو it has a very narrow channel. والمشكله مع النارو channel ان انت الريجيشن بيبقى not as good. And sometimes the little bit of bleeding can make the vision not as good. وكان ساعات كده الناس توقف وكان التكنيك اللي يوز اللي جدا برضه and do some visualization. أو to move completely and get the scope. Once you get the scope of the patient, you put your own. So this is still a very good technique. And once you reach certain, I used one hospital I used this, and the other hospital I used the Olympus. A lot of that is the resectoscope, the normal resectoscope, but they have a laser pitch, which I'll show you later. With that 26, but the irrigation is much better. And in a very, very, very risk area, you can put on us if you want. So you don't need that to change scope or حاجة. كل حاجة the constant scope or كل حاجة couple of buzzes. Again, the very rare I hardly need that. ساعات كنت before I do the anatomical vaporization, sometimes at the end of a very, very big prostate, I kind of do what they call it tidy up. And ساعات تلاقي fluffy tissues كتير قوي لما في big prostate. So you can do tidy up اللي هو الفابتوت اللي هو البطن. stop doing this now. Anatomical vaporization usually give you a very smooth cavity. فالبريفيربل هو الاولمبس، but if there is stores. الإيريجيشن الصراحة هو الصراحة أنا مش فاكر الاسترال ووتر. I think the visibility with the water is fine, but I have to say that saline actually visibility is very good. So I think this is kind of historical thing, or maybe it applies more on smaller channels. Glycine is a bad thing. It's a problem. The characterization, as you can see, you have to be 1 millimeter away from the tissue عشان تجيب اللي هو الستروك. The further you are, you end up with coagulation. The closer you are, you end up with vaporization. So this is very important. You have to. So ممكن تبدا تعمل كده you think that you're doing something actually nothing. You have to do effective vaporization. You have to be very, very close to the tissue and have a plan. And it's like brushing. Until you finish, then you move on the second layer.
في fibers الصراحه most fibers much stronger than this one. Because it's very strong, it actually has a channel inside through irrigation. Irrigation inside the fiber itself علشان تقلل التمبريتشر بتاعتها. لان هي كان temperature very high فانت with charring. فانت مش عايز تحصل charring في الايه؟ في الفايبر نفسها. That's why there is irrigation with the emulsifier. These nanospores, the fiber having that very important impact. Yeah, you make it almost straight. If you build it, you will end up with destroying the damage. So this is very important. And the organization of the whole steady, and it's kind of a pain to brush. You brush it, وإنما تبتدي كده lower زي channel. You finish one side, that's the channel down. You can do it to the top down. Usually it's better to do like this to allow irrigation in and out much easier. Because it's very important to allow hydraulic irrigation. So it's very, and also to open gap in the whole bladder fibers and start seeing the bladder. So you know that you can have a prostate that is directly the bladder. You don't need to worry about it, but some of them are very high. This is only going out. So you can have this irrigation. يعني أبوش less than 3-4 which is 3-4 pounds يطلع كعصير. Also it all depends on how many fibers you لا no the moxie fiber 650,000. You very unlikely to have 650,000. So the capacity بتاعتها can on for bigger size unless it's حسب فيها focus. أولي كان fiber use in the year. So they تعرف إن هو في الديتيلز ده depend on how if you use fiber I think the precious price. وسometimes it becomes generated, it becomes free or not. كل حاجة مش عارف بالظبط صح. مش standard expensive بس طبعا الحاجة اللي can use
There's a fiber market, one box. So the demand of box واحد
بس single use.
Yeah,
لا هو مفيش حاجه صح. هو النقطه ان انت دايما الدايركشن انا بعمل دايما ساعات كتير قوي اللي هو التلف انترفيوز دي مع الاندستري كله دلوقتي انت عارف حتى دلوقتي ما اعرفش ونشيل صح يعني ما عايش شيء قوي يعني
حتى بس خلي هذا الاول
اصرار ولا يعني
الكوندكتور
السيستم.
ولا
شنو هو مرتاح نفسيا؟ او سينيور ستاف من
لا انا to be honest I'm with it. يعني flexible cystoscopy we move completely out of the always flexible هو sorry and the price بس ده اللي يجوز سكوب سكوب لا اسمه ايه؟
انا يوز تو صراحه يوز 1 داش 1 في واحد شيء لا توصل 70 كي اب يومين او في
ما اعرفش هذا ماركس يعني انت اصلا لو قعدت ادخل يوم بانفكشن اسبوع خلاص ب 10 سكوبس على طول وانا بيفهم الديفرنس يعني في البرايفت عشان انفستد ان اليوزبل they don't just throw it away بالك لا استنى تستيك في ذس اتليست كمان سنه او مش عارف ايه عشان كوست افكتيف صحيح فهو يعني نشوف you get a patient with an infection because it's clean it's not sterile all the flexible cystoscope they never sterilize it they only clean it.
We are talking about
That's the
we so ask about the price. This means that there is not
I'll keep it to the end. I'll make it more exciting.
fine. Just I think we're not far away from. I think I'm not far away from the points that I remember اللي هو أنا دايما بعيد وزيد في الحتة إن أنت you have need to remember that there is efficient evaporization and there is waste of time evaporization. You can sit vaporize for 1 hour and you end up moving on, and you can sit for 10 minutes and you remove 10 times the amount that you've done. It's all about effect. Because I said we start with apple, don't worry, come close because you get worried sometimes. It looks fine and safer, and also you get the instruction that you have to keep the laser away from your lens action. You don't destroy the lens, and you have to say. So we have to stick to these rules. But also eventually we start to reach a stage that we know that this is safe, and then when this is closed, this is safe, and then you find that you actually applies much quicker and much better. So the distance is very important. Working distance. We can understand that this is, and see, and I will show you 2 videos. One of them is effective evaporization, and one of them is I will also let this effective. When you find that tissues are kind of يعني evaporized حتة هنا وحتة هنا من هنا, فits technique is very important, but you find it not satisfactory, and then eventually the next patient you find it not. And interestingly, despite the non-satisfactory vaporization sometimes, patient and it heals nicely, but it will be like rather than a nicely open cavity like this, to be slightly active, but it's still a good cavity. So it's despite a less effective technique, still it is still very active. We talked about coagulation, so fine. So keep the fabric constant. Don't stick the fabric to one point because it will start going deeper, even though it has to be all the time up and down, or actually just rotating for just take be perpendicular to the tissue. Once you go higher up, the distance will be away. So you have to be always 90 degree, 90 degree, 90 degree, 90 degree, 90 degree. So you always keep 1 to 2 millimeter distance from the tissue for the 90 degree kind of coagulation. 90 degree, if you do big swipes, will not be a 90 degree on the tissue. So this will be ineffective. So you have to kind of make it small, and keep moving all the time. 1.8, 7, 5, 6 cases, you'll find that you've got to do it without notes. You will master it quicker than this. You don't touch the tissue as well. You're very close, but you don't touch it. Because if you touch it, you end up with sharring, and the sharring will destroy the fiber. yes, the tissues adherent. And if it happens, just go out and clean quickly before it's destroyed. So clean the fiber with this tissue adhesions, this is exactly what I was saying, and don't overtalk fiber at this point. Talk don't bend the transactants with that. Without noticing كده you can keep. But having said that, this is almost not possible with the Moxify. This may be applied to the old 120 because it was much thinner. But having said that, the 125, 120, the old fiber, the 121, is actually the one that the GG recommend for the application. B120.
Some need to touch the tissue.
So if you have the مشكلة you take it out and clean it. That's fine. But eventually you find yourself learning how to come on top of it and start somewhere. That's why if عاود حاجة افتكر these are the two cases. في space هنا وفي space هنا وفي space هنا وفي space هنا. That's why you always start here or start here when you have a space. And then you build the space down and up. So if you start in the middle, this will definitely happen. But some of these processes are huge. Specific, when you fill the bladder will start opening things. That's why when you carry on, huge cavity. Some people say, "Hush, the tissues because the wall is open." And that's why I kind of feel that it's not a bad thing. It's just to have a plan, finish the vaporization as a one go. Not high pressure because you're going to overfill the bladder as well, but not to empty it now. Then there is a laser time and there is an operation time. The difference shouldn't be more than 1.5. Laser time 30 minutes. The operation time shouldn't be more than 45 minutes. Otherwise, you'll be wasting a lot of time and getting out. And once you get out again, you get actually ooze, and it may look less bacterial. The old fiber actually, the two fiber is not accountable for this one. Not always, I can start in that use. Actually, now I prefer to start that use. Stop, have a look, if you're in the tissue, come back, the rice tissue, release it, this one, brush and establish a reference plane, which is the logic. Or, this is kind of moving up and down. So this is the movement. And then you move area from the bladder. Usually you come from bladder neck toward the from box. That's not from bladder neck. So then can you do the other way around? You can. If you can't do something, I don't think it happens with the resume that you go and do stuff that. And this is where we recommend that you can't start from the distance to box. But I don't recall that this you have to have a very huge middle loop not to be able to get in the bladder. But most likely you'll be able to. But you can. You can happen. So this is kind of the viper. You finish one area from another one. I tend to do that and use first now before the video, which actually this is an old slide. I did it on the slide. The deflection that we that should always look side, don't look down. You can look down, but when you rather make it this way. In general, I tend to look sideways. And even when I do the mini loop, I also come from the side and come like this, not like this. بس ساعات بيبقى small mini loop is you have to do like this. But be careful not to move the opposite عشان التايبون there was a case that ended up with big investigation وراح المحكمة that a patient had really pushed pre-licensing and it seemed the surgeon wouldn't do it. Yeah, exactly. Yeah. So it was a kind of, and there was no major damage. I think the patient did stenting and it was fine, but some patients are quite big. Edema. ما اعتقدش انه اسمه هذا الستيج. Epic tissue, yeah, we have to be careful. That's very important to use epic tissue, and it's easy to control this. It's not difficult. We have the investigation of your supervision and also the capsule. Also the capsule, يعني أفضل you open the capsule or to be not as effective, and you know that this is the capsule. But to be honest, you don't need to reach the capsule. Who need to reach the capsule? Unless you do imagination. Capsule fighting. No, just okay. Actually, the provision is much better than anything else. And it's very unlikely to do a big cut in the capsule. بس هتلاقي نفسك أول اللي بيحصل دايما إن أنت big vein. تعرف أنت بتاع الكبسول. This is what it happens. The extra capsular veins are the one that will not be vaporized easily because these are the chunky ones. And the only way to deal with this is just finish quickly the operation, put the catheter, 2 minutes traction, that's it, stop. And the ooze after. So if you do this with a QRP, you have to run a push and you have to keep traction for 2 hours. At the beginning, I remember I used to come, what's that? It's like frank blood, like kind of humping vein, and I used to take it out for 3 way, wash out here. لغايه ما دي مره واسكت وقال لي كلمه this is lazy. Don't worry, take this, give it 2 way, give it 2 minutes. And this was, that's it. Since then, I don't push it. Even if it's a heavy bleeding, you just put it a few washes and it will stop. Unless the patient has a additional problem, that's usually correction. But usually it will stop. So laser is not, you will not cut it, you just scratch it. So it's not, and even I'll see, most likely see. The average time for 50 system that is not more than 30 minutes. This is probably depending on like a very, very average. You can do it much quicker than that. حواليكم يعني بيقيس كبيرة الفيتش بيقيس 10 minutes. Catheterization, again, we talked about that just you can take it next morning. And always depends, the catheter time, it depends on the patient presentation. Patient retention, second. Patient coming with moderate mild symptoms, take it next morning if you want. Big prostate, no. Take it, keep it extra few days. Like it's a multifactorial decision, not one decision. Well, anybody now who have the experience of TUR that will take this decision for how to do that. And there's no need for application. في ناس يتشبه كاثر في الريكفري يقول لك دول 24 hours most of the patient can take that catheter next morning. So consider it will be longer if a very large hospital function discussion or decision taking faster. So that you want to give it some more time to eat. Actually, if you feel that you're needing to move enough to choose. Most of the care that we talked about this before, non-stimulative treatment of patient after looking at session. I used to give this to me, I stopped giving this anymore. Analgesic, mild analgesics, not some patient, they come back and say, we need to use analgesic at all. No sense, I think the 6 for 2 weeks, that one usually 3 days is more than sufficient, but we take it easy for about 2 to 3 weeks in stage or otherwise. Learning care, the procedure is very reasonable, but you master it after 30 or 40. Like you're comfortable doing anything size, but you can't be left alone after 2 phases. And I was left alone after 2 phases or 3 phases. But I know that this may be resulting in one patient have to come early for second operation. So if you want to be, or maybe 4 or 5 cases, someone around you, and someone can give an advice on 10 cases. That's maximum 10 cases. You feel that you're very comfortable to do usual in most cases, 50 patients, and you want to do 100. Trust me. عامل مش موجود. اللي هو بقى مش اللي هو ده ventilation, aspirated ventilation, scope, you have to move this. So احنا ده بقول لك the farmer have to be here, but not here. So your scope have to come with you. So you have to move the scope up. So you can't still be 90 degree. So always the organization has to be 90 degree. This is needed. Coordination of smaller beats is a lot of work. So there is a kind of question mark what the efficacy of green light laser in dealing with coordination, or a bleeder, not coordination, because it's a coagulative and it's a vaporization and coagulative technique at the same time. But if you're a bleeder, can you actually do it? Yes, you can, but you have to identify it, you have to sit with it, and you have to give it time. Because people think it's like normal coagulation. You touch it, stops. No, it doesn't stop. You have to sit tight for maybe 20 seconds. Until, yes, it is clear. And it's incredibly amazing when you touch. It's likely, you have to identify first. Because the problem is you go and the bleeding is somewhere here. That like QR, you can't. The best way to go and find the bleeder that just keep coagulation everything. The same thing apply. You can't close. And if it's severe, just leave it and go somewhere else, and it will solve by itself. But if it's a small after you still can do it. There is a different technique. I'm not sure how it's not always effective. If you have a bleeder here, you look at with the other side. And make sure that this is not facing anything bad. Touch it and start vaporizing coagulation. The beam will go away, but this will be hot to do coagulation. So the tip. But this is a technique that doesn't work. You have to really be very safe. So I will not give you that much. I think we all discussed all these points already. I think Farah يعني اللي هو التيبيكال 40 50 جرام بروستات نتفرج على It's not a huge prostate, it's a reasonable size, and this is what you want to teach, learn people or show people that are size. واحد من السوشيال سبيشالز عندنا هو الشباب ده شيء كبير عارف خالص سوري 26 اللي هو السكتوسكوب السكتوسكوب شيء على بالضبط في الفيجن بتاع كيسي لا ديستنس شو رايك قصدك ايه ديستنس ايه كيسي ده كيسي ده ديستنس
just
we know the styles that typically instructed بالظبط and we know that's around 40-50 this one is around 40 just not أنا مش عارف هذا أنا استعملنا البروسيس كتير شوية عشان بس this is a kind of I think the whole thing is 10 minutes. Oh, it's okay. That's good.
طب في سن معين للشيء؟
You can start from 80 and you go up to 120, 140, 160, 180. I tend to usually start with the 80 عشان شايف ان هم congested vessels يعني كل congested vessels you can touch with 180 to coagulate easily. وبعدين we go up 120 I jump usually 120 ولاد اطمن ان مفيش bleeding قوي وبعدين I go to 140 و 160. 180 بقى I will show you when I use the 180. I don't usually attempt to use 180 to do vaporization, but I use it when I'm doing اللي هو الانفليشن. كل واحد 12 فعل. هو هنا غالبا ابتدى ب 120 لايت عشان ما حدش يقول بس ايه اللي هيحصل؟ حكى يو نوت ستوب the people will stop.
NADA بلاش ب 120. NADA ب 120.
I was expecting how I started slightly high. I usually start a little bit low لغايه ما افتح عشان ابقى حاسس بالريليشن كويس وبعد كده I moved to a higher energy. بس شايف how so a real time كانت كده تظهر after كام 15 seconds. I will be wasting time on this just putting in and out just things and والبريدنج لغايه ما تفتح بس الشانل الفيجن يمكن مش دايما يعني انا I have to say that this is not the operating by the way. This is just one of our military doctors who's doing this procedure. So he's learning. This is a kind of an early learning curve. It's not someone who's been doing it for a while. But back to this curve, it starts with nothing. This is not eligible yet. So the fibers بتفتح ازاي؟ Well, this is small prostate, that's why he was working at both sides at the same time. If it's a bigger prostate, he will finish one side. وكل واحد change performance technique. يعني you do whatever you want. And this is the good thing about it, like that you do whatever you want. Any quicker than this? And he's still starting. وبعد كده adjust actually. بس زي ما قلت لك في اسمه بروسيس ايزي بينبه ايه؟ شايف الفيجن بقى اول ما ابتدى الشكل يفتح الفيجن موفز اوتوماتيك when you have a little bit of acceleration. والريد شايف الريد؟ You see this there's a red dot. You should be seeing it all the time, but not as long as this is really not touching your head. The position can almost see the red on this side, or there is a blue side on the other side, or the purple side. And this should be this should be your vision, and this will be a safe distance from your brain telescope. حاجة برضه مهمة قوي شايف البابلز دي الحاجة بتاع البابلز ده مهم قوي البيتر فابرايزيشن اللي انت to have a medium size bubbles بس كده شايف this is not what I want to do so it's absolutely fine okay in and out طبعا الحاجه اللي عملها هنا دي complete useless. He needs to come closer. يعني هو لازم يطلع في سكوب وبعدين التكنيك يعني شايف الكشف دي كلها المفروض تقرب لها مش من بعيد يعني I usually will go up here and come like this. This will be much more effective. وبعد ما تخلص الاكل تفتح بقى كل شهر happy that you have reasonable looking cavity and it's also an estimation usually انت يعني in 40 gram poster you need using less than 100,000 in and it's one of the average energy you consume even less now maybe 70 or 80 يعني انا اعتقد ان this will not more than 60 or 70,000 joules used in this case. The bigger, at the maximum, yeah, we reached the billion before, 2 fibers. But this was kind of a waste of time because you do a big operation and maybe the vaporization technique was not effective.
that energy, you will use much less energy. ولما في فيديو تاني I'll show you how we do this. ده الكاريشن، شفت الكاريشن اللي هو بيعمل وانتوا عارفين دايما الحته بتاعت اللي هي الاسم اللي هو الفيرب بتاعها is more vascular and you don't and it usually is no muscle it's a pulse and once you do the catheter it's stop by the push line. Very
Because basically the borderline slightly less in the PSA.
قول تاني كده.
Patient with the PSA. Do you prefer to take a suspicion?
بص
It's
so it's two different stories. So BPH, this is so I always say kind of that the claim that the advantage of HOLIP or TRT for the BPH diagnosis is something from the past. Like if you're diagnosed prostate cancer, any patient with BPH surgery will do PSA. And you're going to examine. If the examination of the PSA is abnormal, good to do it. MRI. هتعمل MRI. Multiple MRI. If the multiple MRI is showing something suspicious, you will not do the patient. You can, if he's going to have radiotherapy. يعني مثلا أنا عندي عيان in his 60s, I will never do bladder outlet surgery. I will diagnose him first. I will do targeted biopsy first. وبعد كده, because most likely go in the direction of follicular prostatectomy. اعمل له بقى جرين لايت النهارده ولا اعمل له TRT وبعديها 4-5 اسابيع يخش يعمل follicular prostatectomy which would be a horrible operation. ولا diagnosis ثيرابي. بنعمل ايه بقى ساعات؟ عاد بقى in his late 70 early 80s وانا عارف ان هو he will not be fit for بالظبط. يعني انت بتقول مش شاكك بروح داخل اعمل بابسيس وجرين لايت. تارجت البابسيس وجرين لايت. هو عيان اولد وهاي ريسك. ايه اكتر حاجه يصير في الدنيا؟ جرين لايت. هو في نفس الوقت طلع كانسر. حاجه خدت هرمون ولدي ثيرابي وهم بيقولوا هو انت اصلا لو طلع عندك كانسر وهو عنده obstructive symptoms يقول اسك مين سكان بيقدر سيرجري فانت ضغط عصبي بحاجه واحده فان انتوا تفرق وبعدين معلش هو البرف هو البروستات كانسر بيجي فين؟ يعني انت if you find يعني فاكر التي 1 A والتي 1 B ما حدش بيسمع عنهم دلوقتي دول ما بنسمعش عنهم خلاص اللي هو عملت تي ار بي لقيت 5 في لسه بفرق لسه 3 ولا كانسر تحطه تقول له this is not cancer. There's no recommendation to treat this anymore. If you find Gleason 5 or 6, you can Gleason 8 to 9 or 10, then you misdiagnosed the patient from the beginning. You didn't put a finger on the patient. If you had an extensive easy you have to reassess how did I come to this? How did I do a patient that I did not necessarily? So this is my argument now that we actually shouldn't be using tissue diagnosis for what you are doing. You have to diagnose prostate cancer as a prostate cancer. Part of your assessment for BPH is to exclude prostate cancer. صح؟ يعني هو العيان ده محتاج كمان 7-8 دقايق عشان ما يبقاش هو actually this was when I downloaded these videos it comes هو السيستم عندنا divided into 3 or 4 ففي there is a completion يعني فهو مش هضحك عليك واقول لك ان this is only 5 minutes it's not 5 minutes it takes maybe يعني 15 minutes يعني you can finish a small process in 15 minutes bigger prostate the average is half an hour and bigger prostate we take an hour يعني I don't think that I'll stay more sometimes we can stay more for 1.5 hour تشربوا حاجه ولا نكمل والله بص البرزنتيشن ده
في حته كمان مهمه
يعني اذا في مجال نخلص الجرين لايت وبعدين نعمل بريك 1 اور حق صلاه او غدا.
او ان شاء الله. This is بقى ايه اللي هو this was the patient had a stool. خلاص واتعمل له ضرب الاول.
انا كتبت البارحه وكلمت عن
الستول مش كويس بس السيرجن ديزاين ان هو يموف ذا بروسيس فاست وده ممكن هتلاقي التكنيك هنا انا ما كنتش معجب بيه ليه؟ لان هو اخذ حبه من اليمين على حبه من الشمال تحس ان هو عامل سيستم لسه ماكسن فيه. فانا I'm showing you like يعني less productive technique. يعني he's kind of you can see that he's I usually tend to advise هتلاقي هو starting stop. Advise انت to finish one row here and then go for a second one and then a fourth one. So you take it like one swipe, and then you go back in and do like this until you create a very nice smooth cavity this side. And then you go on the side and do this. فهتلاقي حتى اللي هو الهاب technique دوت you end up with lots of tissues here and there, but still they will be very good. And this is what I call the early learning curve. اللي هو التالي you're not confident in using the fiber قوي. فلو توريكم اللي هو ايه الهاف good and good and this good, but still very safe. Someone who's like a very early training and is still doing a very good verbalization. وأنا ببقى واقف مستنبط. يعني كحد يعني if you supervise someone, you know that he will not do massive damage. Tell him that please don't go beyond this, don't go beyond this, and everything you do will be fine. Very unlikely to get massive bleeding, مش هتعور حاجة، مفيش. But still very very nice and lovely. Let's move on by يعني شوف كده التيشوز هنا is not as nicely removed as the previous one. So the way you do the vaporization has to be more effective. So this is the least effective. This is the picture. One of the patients had PMP. We had to look inside, and this was 2 years later. ده بقى ايه الفاب ابليكيشن اللي هو rather than you go vaporization like this, you go in anatomical up and down, and then you join them, and you leave it to stop, and then you put the energy to 180, and then until you vaporize it. Or you can push it and activate it, and if you have no sleep, you take it. But you don't need this. You can't say it because it will not take that much time. And I'm going to show you this. ده السيكتوسكوب اللي هو العادي. والسيكتوسكوب بتاع الاولمبس في اكسترا شانل ديزاين. To use اللي هو الليزر شانل you have to take this one and put it. It will not come on top of it, so this will give you a bigger chance. وطبعا you can easily if you want to do coordination you can use our rope channel. You don't need to change scopes at the same kind of scope. So that's why I found that this is actually one of the best channels. That was still this is kind of it's just probably 60, 50, 60 type of stuff. Not massive amounts, it's again good for video. And size of the video, which if you can just the vision show it. So I don't know if push on the snap and marks, also the views. away from بدون الشاطئ فوقيها لما يكون بدون بركب فيها fine. You still work there is I don't have this video actually. But maybe you bracket for example you will see it and it's still very safe to do it. But this will be done by proper vacuumation. Yeah, you cannot just and then you leave it in a stop. And either you kind of surprise, or you can just put it like instead of porcelain you can try to put the microscope بس هتبقى almost separated completely مستحيل. فضل and you don't separate it completely and use the sectoscope. This will be jumping. بص بقى انا جبت من فين هنرجع حاجه تاني عشان تبقى سرحت بوشن حلو. ليه المشكله؟ في مشكله من تحت اللي عملته الناحيه الثانيه بس هو يعني يستوعب على طول and cover like all the way down until you reach the veil بتاعه.
اسوي لاند مارك لا ما في اسوي لاند مارك
كنت معك. After certain time, you kind of know you are. And once you come back up, this is the sphincteric area. So, but you're absolutely right. You put that up. For proper evacuation, yes. بس في الفاكيوم هو دي مثل الفاكورايزيشن اللي هو الاتوميكال فاكورايزيشن اللي انت you control. No one doesn't control. You control where you want to go. And the advantage بتاعتها ان انت you plan something in your head and you follow it. You don't need to go much deep. ابص حوالين سبريد اهو هبتدي فانا سبريد from the top واخد بالك انا ايه this is I know here I'm coming behind ايوه كاني بعمل ابلكيشن بس الابلكيشن بمزاجي مش بمزاج الاداء. And this is what I think is an advantage. عشان انت sometimes the adenoma takes you somewhere you don't like and start dealing with that. This is you kind of plan it and then also you plan the other side to be similar. So you end up with a very nice little plan. بعدين بقى نزلت تحت خلاص did a nice move from the top end. بعدين تحت بقى على الساعة 7 we start doing the other way around. And then you need to show the next one. ده edited شوية بس هو actually يعني probably too half.
تعرف انا اخذت من 11 خلينا نقول 9 من 7 ل 9
بص قلت لي كده
11 ل 9
هو 11 لغايه ما نرجع كده
ايه
وبعدين
جيت من 7
واخد بالك انا بعمل ايه؟ انا بفتح فايبرز I'm opening fibers rather than surprises. Sometimes you can push it and you make it flat. شايف الفلاتنس ده؟ Okay? And you come until you start reaching the other side. So actually, we're kind of separating the fiber, cutting its size. You can push as well if you want. بس I tend not to do this لأن أنا عايز أركز tissue. I don't want to have big chunks inside. But at the end, sometimes I push small part and I wash it out later on. بروح أعمل كده غالبا. واخد بالك إن أنا إيه؟ one of my plan في البلان بتاعتي إن أنا I drop the bladder neck until I see the bladder. But I don't cut the bladder fibers. عشان كده the ejaculation response في الجرين لايت ليزر is much better than the theory. احنا بنتكلم في 67 هنا 40%.
But if they have you gave that to you,
So perfect, good question. وانا بعمل اللي هو البلينز اللي فوق تحت اجيبه 12. اوكي انا عايز ان انا اللي هو الكاونتر دي ان انا انضفها في الكبسول. Once I reach the stage that I'm close and it's stuck, I will raise it up to 180 and will come from bottom up and top of the leg to visualize parts, which will start showing in a second. أنا حابة من فوق وحابة من تحت، ولا حابة فوق وحابة تحت. شايف السايز بتاع البابلز هو ده السايز بتاعه اللي هو الميديم سايز بابلز. ده معناه ان انت you're in a good distance بينك وبين التيشو. خد بالك انا فوق وتحت وابتدت اوريدي almost started to join together. كان في حته هنا عشان منها ولا لا، الهاند موفمنت. شايفين ماي هاند موفمنت هنا؟ ماي سكوب موفمنت. السكوب يعني لازم الاثنين يطلعوا مع بعض. lovely size bubbles. شوف size bubbles ده تعرف انت very effective proposition. الفيري سمول سايز bubbles معناه انت بعيد شويه. وبعدين ابتدي تجوين بقى من هنا ممكن تروح اخر going with the direction of the what I call the imaginary capsule. You're creating your own capsule. بس at the end you find that this looks like a capsular fiber. بس تزيد الحته اللي شايفين هنا دي capsular fibers. انا دلوقتي خلاص I'm almost separated. I'll look up. This is 80. شايف how quick it is. شوف الفابولايزيشن وشايف السايز of the bubbles. Very, very, and just you eat it completely. Probably it may be quicker than if you use the oscillator in and out a different machine and all this, and much safer. أنا جاي بقى من فوق على راس اللعبة، حاطة فوق لغاية ما إيه؟ This is completely disappeared. هنا أنا بسرع شوية مرة ونص فالموفمنت بتاعي أبطأ شوية بس عشان ده بيدي ده سلايد في الصور. وبعدين شوية fluffy tissues هنا ولا هناك you come back and apply it, which is something that it's not possible in Hollywood, for example. And in Hollywood they have to put manual creation. لو عندك tissues hanging هنا ما اعرفش تعمل فيها ايه تاني. You just leave it. Then you can go and tighten up because you have the pricing power.
And 12
شايفين بس اتفضل على ستوكس بقى خلاص. انا ممكن كان هنا ازقها وايضا to collect later or cut it three pieces or so but you don't want to do this. انا اسف this is
عندي 12 مش في سبيشال ايكويشنز توصل فين؟
ما هو انا حاسس ان انا جيت فين؟ انا جيت كده ورحت نازل كده ما مشيتش كده. فانت you have to انت you know the anatomy. فانت you just follow the anatomy and you want to create a good cavity. احنا مش يعني and these little size and it's what we call بس بقية الفلاف tissue دي by the way دي all separated tissue. فأنا I'm working on almost separated tissue handling بس الحتة دي fibers أو يعني small pieces tissue.
حاول أقوي شوية مثلا من السيرفس.
أنا مسافر بقى.
على الأنتوريف.
مش حاجة يعني أنت لو عملت كده وعملت كده الكمشة هيبقى موجود لسه. عايز ساعات بينزل عليك حتى بس افتكر ان انت الماكسيمم 1 ملم organization will not be a problem. You can repeat it now. Really it's not there's no guarantee that it will never repeat بس يعني very honest. الأوبريشن بيخدم مني قد إيه؟ التوتال half hour. So it was kind of, which is the average, 60 minutes. بعد كده آخر بقى شوية تراك أوت التيشن. Let's move forward slightly. So I'm very close. Oops, I got backward. Okay, now we're doing the other side. The other side, and I start from the other side. So you're flexible. You can start from the top, or you can start from down. هنا I start from down, أنا كنت عايز أسيب الميدل لوب لوحده في الآخر. And I found that it's kind of I separated from this side, and the middle loop was almost being part of this. So I decided to create اللي هو الجروف بين الميدل والليفت side وما بين الليفت بي والسايد.
طول عمرك why do you delay dissection of the median bone?
تاني كده.
Why do you delay median bone dissection to be the last stage? Why if you start with better irrigation?
Once you open the sides, you get irrigation. But it's by creating this, now you're creating a very good the planning بتاعك اسهل. You can't do it. So it's not complicated. So I don't think there is one way to start. So when you look at visual accommodation, lots of people say finish the middle loop first and then go for the sides. Okay? But this middle loop is not that big. The main closing, the block part will be small, but it still need to be done as well. Again, this is almost a vertical shape here. And I'll show you how the middle loop will look like. Again, I come from above and down until I separate it and do the same thing. دلوقتي بقى I'm working with the middle loop. شايف منظر الميدل لوب دلوقتي عامل ازاي؟ You just take the move. And you jump it from below, and then you وبعدين ممكن يبقى completely activated with a team very very thin to cut and then start like if you want to do if it's a huge one you can like بس again you have to have a perspective and you have to have the ethical perspective. Here we just give a small one. So more time of presentation in this.
And I am using 180.
Well, when it comes to near the capsule, I usually drop the energy to 140, 160. When I'm using it to vaporize this tissue, I go to 180. So most likely I was 180. I don't remember to be honest exactly what that. Most likely when I'm vaporizing tissue, I go 180. Once you 140, 160, it's a very, very, very light. تخيل attack tissues disappears. It disappears, and it's not there anymore. Therefore, you remember the old movies of when the science fiction movie when they get the laser gun and someone disappears. It's the same idea. You're actually using a laser to make tissues not there anymore. Where is this tissue? It's not there. يعني and to be honest, the green light laser is probably the laser. I know that lots of people are reluctant to use Googles and things like this. The only green laser that I still know about is a green light laser. You have to do this because it's a powerful laser. The home you don't need to. It's a very good laser, but this is a very powerful laser. But still, very narrow, very limited distance. So it's not that. That's very nice. Did you start seeing the capsule fibers? And this is a little bit of an active tissue, but this is I will only wash that. If you look at that, maybe in the next picture, I'll just hope it will come out. It will come out just. So it's kind of you wash, you just irrigate it out, so it's quite small pieces that is left. Now, I'm like big pieces and you really feel that this is huge, just narrow until it's a very small stroke, and then you can dissect it like instead of the musculation if you don't have musculation. And it will be still, you're cutting in a dead tissue, no blood, zero blood. The living tissue is crystal clear. I think we're done. That's enough for the green light laser.
I'm seeing it's very effective on all of this. Are there any precautions you are looking for?
Stop. يعني انا اخذت بالك وانا I'm drawing the line. This was 120, not the 180. وبعدين it's over what the patient wants. If the patient is very keen with ejaculation, then you have to be very cautious with your and be slightly aware. Okay. If the patient is not keen, old age, what happens if you apply sexual? No, if veil is safe, after the veil is not safe. So if you vaporize the same,
It's magic. It's like, once you make this, it's like,
That's why you always work this way.
like that.
It's not like that. It's very hard. I think we're done with that. Enrico, who, if you been here, he has shown you this, the actual application. This is present, and Enrico is actually one of the person who founded the GGG group, and we have lots of publication on this. And this is a very good video about evaluation. I'll leave it on, but I think that to have refreshment.
Real quick, for 1 hour for time and lunch.
This is by the way YouTube, so it's not the video.
Okay.
But this is exactly the proper the same language technique that we're using at home there, but using the green light. So this is kind of the flexibility of the green light that you can use it for this.
What are the tips that you use for the patient and the antibiotic?
To be honest, I do the same. I do the same. I can't.
Same of the setting maybe or
Yeah, sorry. No, maybe I will just be slightly do the 120 and avoid as much as possible to go 180. ساعات if you have a large congested veins, so don't wait here. Superficial visit عشان تلاقي superficial take out the stuff that you said to school otherwise. It doesn't need it. Now I don't just go somewhere else. What's the level of this thing? أول ما بدأت دي مشكلة أول ما بفضل what's going on? But it's all about just needing to fill out and then try to find where you are and just your application and just finish the procedure. Very basic. بس compare بقى development application at 180 مع الهوليك there's no difference. أنا دايما بصراحة واحد بيستند الريفرنس بتاعه. كنا اتكلمنا شوية على الديفيدنس بتاع الهيلينج. لو بتبص هنا هتلاقي البي في تي zero blood transfusion almost and the least rate of healing compared to the other thing. هو صراحة it's one of the safest here. بس let's move بقى ايه this is all past. This is all past. Let's move today to the new life. The new life is patient is important, but surgeon is also very important. So minimally invasive treatment, I always say that's not good for the patient only. It's actually slightly better for the surgeon and for the legitimate surgeon. بس حاجة مهمة قوي إن إحنا always say that if we count the years that we spent to learn medicine and to learn some specialty of medicine and to learn a technique in medicine, this is a minimum of 20 years. If you spend all this time to learn something, you need at least double or triple this time to not double the same time, or at least double the time to be productive and to pay back. If you decide that you're going to do big operations all the time, you will end up older and less fit for operating much quicker. However, if you do shorter, less stressful operations, this will increase your productivity in the long term. So it's very important that we look at this. احنا ابتدينا نسيبه back in 2017. This was the group on the left side is Lynch and Henry. I am Henry, and Leonard is this gentleman here. He's one of the early people who started doing therapy first. He's from Sweden, and
he taught us how to do this. And there's other people. This actually was in KUA16 before it was Boston. When did you buy it? 2019? When did Boston buy this?
No, 2018.
18, yes, 18. So it's exactly 1 year after that, absolutely right. And you know who's that, of course. Who's that?
Saudi.
On the left side, you know him? Fraser. You know who's Fraser? This is Fraser. Fraser, one of the, he was originally Cuba, but now he's one of the, he's in Boston, I think he's the UK and Europe, something, I'm not sure. But he kind of started with Zoom with us at that days. I think everyone is doing the Zoom now, right? Or everybody here is doing it. We know what is exactly Zoom. We know all these kind of fundamentals. So water energy, we know that at 78 degrees, you get an instant cellular death. And this is what you want. 70 degrees takes you less than a second to kill a tissue or kill a cell. And this is the concept exactly. But what is more important, this is not a pure heat, this is a wet heat. And a wet heat is much more gentle than dry heat, because the wet heat spread between the cells and kill them evenly. But if you use dry heat, as the other technologies, TOT, things like this, it actually will shine, and the shine makes the distribution of the energy much less and less effective. This is all, we started in 2017, not far away, we were both in the news, and we were kind of hitting, it was very, very easy to adopt, very easy to sell to people. And in March 2021 year exactly, we done 100 pieces of technology that was completely brand new for everyone. So it was an easy sell, and I have to say that we were very, very proud and happy. And we started going everywhere. This is a team from the north. So we went to Scotland, we went to Ireland, we went to Europe, we went to Turkey, teach people how to do this Zoom. And we were very proud of spreading the news. So I don't need to tell people how good this Zoom is, but I think what I need to tell people is to make sure that the Zoom is not used for everyone. NICE was fine. We 2019, there was presentations about it. And for any new area of technology to reach this kind of success, you make sure, first of all, that your patient is safe. So patient safety was one of the good things about the Zoom. So you're very unlikely to cause harm with the Zoom. I always tell patients, worst case scenario, it doesn't work. You're very unlikely to end up with incontinence, with massive problem, post-operative complications. You can get an infection, but post-operative complications like incontinence, significant bleeding, things like this. And it's intelligible, everybody can learn it, easy, reproducible, learning curve is very short. I mean, I was just listening, we were discussing that some surgeons now start doing this operation without having a course of anything. And this is not right, to be honest. They have to have a little bit of knowledge, a little bit of proctoring, but it doesn't need more than a few cases to be reasonably experienced in this technique. And you have to always look at your patient outcomes and make sure that your patients are benefiting from technology and doing the right thing. And if they are not benefiting, there's something wrong. And you need to revise your technique or revise your indication. And usually it's not technique, it's always the indications. The cost is very reasonable. Durability is reasonable, but it's not a TRP, it's not green light, it's not hollow. We know that we have the 5 years data. The 5 years data is around 5% recurrence, but we know that this percentage increase, and it makes sense, because the bigger cost that you're doing, you will end up having a need for a new operation. But this is not a disadvantage for any minimally invasive treatment. That's why it's minimally invasive treatment, because it can be done again. Same idea like Botox, things like this. It's a teamwork. Any questions about the previous thing? I don't think it's just a light introduction to what we're having. So I think what is more important now, because we all know what is you and know what to do with patients, is which patient to actually offer this you and which patient to decline this you, and also very important to counsel the patient and manage his expectation. Because you cannot just promise patients something, and post-operatively, he finds himself in a completely different area. And this is when you get frustration and you get very unhappy patients, because it's not because this technology didn't work or the operation was not successful, but because he didn't know what to expect in the first 6 to 8 weeks after the operation. So if you don't counsel your patient properly, this is when you get unhappy patients. And an unhappy patient will never change his mind. I'll tell you a simple thing. My father. I told him, frankly, you can have these tablets, which is a BPH tablet, and it's off-label because it's double the dose, but the side effects that it can lower blood pressure slightly more, and it can make you feel athenic, unwell, things like this. That's fine. My blood pressure is high anyhow. I'll make sure avoid the operation. And the week after I'm calling him, he's telling me, "Are you trying to kill me? I even counsel you." So despite you counsel patients and you tell them, and he's the closest person to you, and I tell him, this is what to expect. He tell me, I felt very weak that day. I will not give it that again, but I explain this. But this is even after you explain. Maybe I passed it quickly and he didn't take it enough. So not only explain, but make sure that you explain thoroughly. And this 1, 2, 3, 4, and this information leaflet as well. Because if you don't really manage the expectation of the patient, then we are in trouble. And not in trouble because it didn't work, because the patient didn't expect. I mean, exactly if a patient's going for an operation, and you don't tell him you're going to have a catheter after the operation, and you put a catheter, you wake up with a catheter, what do you think he will do for you? It will be a nightmare. He will keep swearing at you, and he will just give you a really bad time. So it is very good to talk to the patient, and also equipoise. Do we know what equipoise means? Equipoise means to be very equivocal, that because there's no technique better than the other, but each technique has advantage and disadvantage. And you have to explain this to the patient. These are the pros and cons of this technique, and this is the pros and cons of this technique. And if this technique, and then he needs to decide what he wants to do. He needs to find what is his priorities. Because one patient's priorities will be getting the best flow, avoiding another operation, and it doesn't matter that if you're going to have a stress incontinence or lose ejaculation or lose erection. But another patient, he wouldn't mind having a little bit of, have an improvement in the symptoms rather than a complete resolution of the symptom, but he doesn't lose ejaculation, and he doesn't mind having another operation, and he doesn't want to risk his sex life at all. So this is patient priorities, not your priorities. So the patient need to decide this, not you. So you really cannot offer him, this is the only option. This is not accepted. And this is what I call it equipoise. So the patient choice also is very important. It's not for mild symptoms. Mild symptoms are for medical treatment, but it can be for mild symptoms if the patient is not responding to medical treatment. So at mild symptoms, medical treatment. Why should I do an operation for a patient and take a risk of? I mean, there's no operation with zero risk. So if the patient is having a mild symptoms, then medical treatment, if not working, it can be an alternative. But actually, the indication is same to any bladder outlet surgery, moderate to severe symptoms, and even retention. And we'll cover this later. Medium-sized prostate is the preferred size, and you're right. Can we go beyond the limit of 80 to 100 ml? Yes. But is this something we should do? No. But when shall we do it? We should do it if we don't have an alternative. If the patient, first of all, will not accept to have anything to risk his ejaculation, then we can tell him that this will do, but we have to re-counsel and make sure that, okay, that's absolutely fine. Your post is 110, 120, but you have to know that the catheter time will be longer, your symptom will not improve, and you may not improve from the first operation, you may need to have a second operation, and you may need to have an extra treatment. So this has to be all clear there. We accept these facts, but this is with the advantage that this will not affect his sex life, and everything will be fine. And you have to be slightly generous with the injection with a larger cost. And I had this example for this 3 or 4 months ago, a patient with 130 gram, 40. He's in late 50s, young wife. And I told him, it's not the right size. You will have a longer catheter time. I'm not expecting you to have improved the symptoms immediately. Probably the right thing for you to have green light laser or something else. Aqua, I don't have enough experience in this, but I have to mention it because it's coming. Sorry, Muslim. But it's just, so you have to mention what is available in the market, and just frankly understand what I'll take my chance and understand it may not work. I went inside, I did the bigger prostate he put extra. His prostate reduced to, I think, his PC was recently elevated slightly. So I measured it, I think it was around 70 to 80 cc. And he is, this guy actually, his post-verdict residual was over 400. So it's actually was another problem, because the higher the post-verdict residual, the worse the outcome of minimally invasive, and we have to consider more cavitating surgery. But he maintained his ejaculation. He's very happy sexually, and he was recently here in Kuwait, by the way. and he's very grateful. And he told me it took exactly 6 to 8 weeks, as he told me, and I was expecting this, and I'm happy that he told me everything. So he was well counseled. And even if it didn't work, so he even said that if it even didn't work, the way you explained it to me would make me accept the outcomes. So this is the most important thing. You can go beyond the recommended size, the recommended indications, but for certain scenarios. What is the other scenario that I would maybe say yes? A frail patient that you can do, you cannot have anesthetic, because this is a procedure you can do in the local. And the patient is in retention, which we don't like to do resume for, or we can, but it's not the first indication. But there doesn't have to be other option. His option is to stay with the catheter forever, or maybe use the XV. We were talking about the XV, someone is using this now. But again, it's not an easy thing, and a bigger prostate can cause trouble and things like this. So it's not a typical indication as well, but there is a maybe 70–80% chance that it will succeed. So under local anesthesia, hardly any risk of complication. Worst case scenario doesn't work. Patient understand this, that's fine. So this is how we can go out of these brackets, which is the guidance for indication. So we have time-motivated patients. So the patient have to understand that his symptoms will not improve instantly. These are the drawbacks. We need to have an operation in the future, things like this. It's only second treatment, so it's what can be better than this in life? I mean, there's nothing that can finish in 9 seconds. But I mean, one of the disadvantages of resume for a urologist that you don't get the satisfaction of surgery. And one of the problems that many urologists will do more injections because it finishes too quickly. And they think, is this enough? I will do more. And this is when I say, guys, just follow the rules. Don't push any more energy there, because when you push more energy, you end up with more harm. And the harm in many ways. Prolonged recovery, sloughing of the tissues, unexpected bleeding, things that really doesn't happen. And this is because I still have 15 injections in the machine. I only put 2 on each side. Let me do another 2. Why? You shouldn't be doing this. You're basically injecting dead tissue with steam again. You're making it slough rather than shrink. So you're actually destroying the mechanism. So you have to be very careful about these things. And this is when I was talking about the 9 seconds and how tempting it is to do more than you should be doing. Clinically proven results with symptoms, we know it works. So when I was talking about this treatment, I told the guy, when we started talking about Resume in 2017 and 18, I told him the first thing I would have done this procedure. The first few cases I said, yeah, this is nonsense, it will not work. But interestingly, it did work. And we've seen the patient coming with, I had a couple of fluid tests, maybe I'll show you one. patient had a flutus of 5, post-operatively 25. So it is working. It's not the common, and the average we know it's from 5 to 10 or from 7 to 12 or something like this, but sometimes it works tremendously good. And also, we have that because we've done at least 1,000 cases now. We stopped counting after 500 cases, so I'm not sure how many we've done now. But many of these patients came back for a second look for other reasons, for blood or for symptoms with not that good, things like this. So we did scope lots of these patients, and a lot of these patients go inside, and it's a TR cavity. So it is really effective, but it's just need patients. So the theory work, it does work. The results are proven it works, but it doesn't work on everybody. And that's why there is a 5 to 10% of patients that it does not work on them. And for many reasons. I don't know. For a few cases, you go back and the patient doesn't, you know that you waited for 2 or 3 months and his symptoms didn't improve. And you go back inside and you have a look, and did I touch his prostate even? And you think is one of two things. Either he didn't have sufficient treatment, or this is a super dense prostate. And a super dense prostate will not allow the steam to go and disperse evenly. That will be a problem. Erection sign. Have you ever anybody heard about urinary incontinence post-surgery? Never. I heard, okay? Not reported in the USA, but I think it was a blind surgeon. So most likely he put the steam in somewhere that shouldn't have been done. I think it was a temporary kind of continence problem. So actually, there is no literature saying there is an actual recurrence. Have you had anything? No, never. I had it of like a colleague mentioned something like this, and sometimes it's not really incontinence. There's a technique problem, injection wrong place, and maybe patient.
For sure.
Yeah, exactly. You're absolutely right. And I always say, check what's going on. Did you actually treat a patient with a bladder obstruction, or you treated an overactive bladder with a small prostate and you injected the wrong, and you did the wrong thing? So it's the wrong indication. You're absolutely right. It can be done as office case, outpatient therapy. This is all easy, similar improvement to surgery option as I just mentioned. And Sora, she's my favorite. She's lovely. I don't know. I can't say that it's like this kind of aesthetic principle. The patient comes for a facelift rather than an actual operation. I mean, he's coming to make his prostate younger. If you look at it from this concept and explain to your patient this concept, a lot of patients like this. Even if it comes back for a second operation, the same thing. I mean, we have a few patients who have this operation now, came 4 or 5 years later, because we're now, 3 to 4 years later, because we didn't have that much for across the 5 to 6 years, who said, I've done very well for the last 3 or 4 years, I'll have the same operation because my symptoms are coming back. So they're using the Botox principle, that you have improvement in your look for a while, and then you get the symptoms again, and then you take more. And probably make the prostate even younger and younger. And you can see she's, how old is she now? And it says this is at least 60. At least 60. She looks 20. She's, yeah, just interesting. I don't know. Is this 2022? So anyhow, so this is one of the way I kind of find it very attractive to describe the patient, especially when I show them Sola's pictures. Pre-assessment is important. You have to make sure that you're treating. So I find no excuse to put the finger on the patient and say, you have a big prostate and you're going to have blood surgery because you have these symptoms. You have to be properly assessed. The patient must have a flow test, must have a scan, must have IPSS. Not all of them need flexing, not all of them need dynamics, not all of them need TRUS. But I kind of say you can't really treat patient based on what he says, because he may tell you the recent symptoms, but not the old symptoms. So you really cannot judge where we are unless you have a kind of strong proof And the best proof actually is the flow and the scan. Obstructive flow, high residual, perfect. You're doubting, then a truss, then you have, and I have to say, truss is not always mandatory, but if you feel that I'm dealing with a 50, 60 gram, that's fine. But if you're not sure, you think, this looks like mildly enlarged. No, trust it, because if it's 20 or 15, then you're actually not doing the right procedure, and this patient had a high blood neck. And usually, and so we had a couple of these, so we work with another hospital, who is our sister hospital, and we have, they work differently. We have what we call it one-stop prostate clinic, where the patient will come ready for flow, have an IPS score, IIF score, will have all of this with specialist nurses with the scan, then he will see me, look at these things, truss him, and even flex him if required at the same time. So proper assessment for the prostate. So I'm almost 180 or 90% sure that he will benefit from what I'm going to do. On the other side, there are obstructive symptoms, not responding to translucid, finger examination. So the standard old way, okay, which is probably 90% of urologists are doing. And I'm not against this if you're going to do TRP and you cancel the patient for other things like blood neck incision. But if you're going to open a resume kit that costs whatever it costs, and you go inside and you find that I'm dealing with a small prostate or there is something else, and this is not acceptable. So if you're planning, and I think there's really no excuse in the current time not to really properly assess your patient. So you have, and it's not difficult to do a flow test. And it's not difficult to ask a patient to fill an IPSS. Flexi, again, I will do flexi if the patient have a lot of overactive symptoms. I want to make sure that I'm not missing anything there. If I'm having a very small prostate, like 25, 30, because you can still treat 25, 30 if you have kissing loops. But if you go inside, you go inside by the neck, then it's not like treatment. So this is the patient that I'm probably flexing. I don't think I will do urodynamics. This is very unlikely. I don't like the urodynamic test. All the three top options, the flow scan, prompts, truss, flex, usually you will add nothing extra by urodynamics except in a very, very, very selected patient, mainly the young patients, that someone with early 40s with what seemed like everything convincing obstructive symptoms, but I still do urodynamics because you don't believe what you do. So urodynamics is not my favorite test, but I will request it if you. Again, fitness for GA, acceptance for LA, all this, and if a patient is coming for an LA procedure, I tend to do a flexi for them because it's a test. I'm testing their cooperability for the procedure. So you know that if you're doing a local anesthetic, you have to have a cooperable patient, and the best test is to do a flexible suspension. So proper assessment, you don't have surprises in the day, and you find the patient tolerating the flexi fine, he will be absolutely fine with resume, even if you do it with lidocaine only. So even if you do just an Anestella check, and we've done this in a few patients, and it was absolutely fine. Again, the patient indication and contraindication, I think this is what we're talking about for the last 15 minutes. The contraindication, urinary sphincter implant, I don't think it's a contraindication anymore. I think it was written in the past. I keep putting it just to see if anybody have any experience with this. Probably not. It's not that common. Benign diseases, I don't think it's a contraindication. My actual contraindication is prostatitis. If patient have chronic prostatitis or pelvic floor syndrome, these are the patient I really don't like to give them resume whatever. I was just, if it's acute prostatitis that was treated, that's fine. But I kind of still try to be shy. Patient choice is very important. If we're talking about fit, 54 years old, prostate 45, acute retention. So acute retention, but he's 54, sexually active, and his prostate is medium size. So we will definitely offer him resume. So acute retention, if it's acute on top of chronic, then you need to think twice. But if it's just pure acute retention, then usually they will do very fine with resume.
Why is treatment
And it was technical complication. It's a little. It was little before. It was a recommendation from the company before it was open.
Right now.
I don't think so. I don't think it's.
It's not recommended for the early adopters. Maybe at the late stage, they are aware enough how to tackle this.
Yes, I think in the early days, I mentioned the early days.
Why?
Because they didn't know what will happen. There was this experience. So,
They consider the heat energy.
yeah. But I think few people have done it already. And that's why they kind of, because it was an old slides and everything, so people keep saying it. But I always put it there saying, I don't think it's a contraindication. That's just that. But it may be difficult if your patient has a penile pathesis, especially the semi-rigid one. Because your hand is rigid, so it's not easy to reach. So this can be kind of a, yeah. But if it's an inflatable one, it shouldn't be a problem. Another example: 73 years old, 185, chronic retention. He's a widow. He's not even keen on sex life anymore. Very large prostate. Someone need to convince me to offer this patient tissue. I don't think I would ever offer him tissue. Do you agree?
Yeah.
Another 80 years old, prostate site reasonable, chronic retention, controlled diabetic. So probably I'll offer him, but I will again offer him both options. But it would not be a contraindication. An elderly guy, 110, chronic retention, significant morbidities but still active. Then it will be actually a priority for me to offer him this because I don't want him to have anesthetic. But the previous one is maybe yes or no, but I'll kind of be less inclined. But this one, I would probably say, yes, we can offer you Zoom, and because we don't have lots of other options as well. So the recommended learning here is 4 to 6 patients, start with swollen prostate, and yeah. We've seen few people come with bleeding. They tend to self-control. The biggest mistake, if you see blood, you go behind it. So if you see bleeding, so sometimes you do the injection and you put the catheter in his blood there, and people are, what's going on? Let me get this sorted now, and they go back with the score. This is a big mistake. Very unlikely that you will encounter bleeding that will not stop by itself. To put it this way, the worst case scenario, and we've seen, so in the early cases, we went back to look at patients because we were worried about bleeding, and we didn't understand what's going on. And it's a complete mess because it's edematous tissue, it's inflamed tissue. You go and decide, I want to cauterize here, it doesn't go right. You end up with doing QR, a very bad QR, and end up with more bleeding. So we kind of started to say that this is the only thing to do. And I remember the first patient that we sat by, me and Richard Henley, and again, injected, done the injection, put the catheter, and in the recovery, you know when you have this kind of clear red, and you know that this is arterial bleed after, and then arterial bleed. How can we do an arterial bleed? That doesn't make sense as well. So we decided to set tight and to give him some what do you call it, tranexamic acid. And 10 minutes later it stopped. And then we started to realize, going back to take these patient data was a big mistake. And what have we done to make this an arterial bleed? The worst case scenario, you go into an arteriole with the needle, but you did not cut it, you didn't puncture it. And most of these arteries, small arterioles, are not big arteries, so they will spasm. And also remember that the prostate is still there, and the edema and the heat will make it stop. So sit tight on them, and going back is the big mistake. I know you may end up have to go back if there's blood clots, and it may be inevitable, but try not to reach the stage. Wash them.
You have to make the traction.
Yes, traction, tranexamic acid, and sit tight and trying to make sure that his blood pressure is not shooting high. Because this is the other thing. Patient agitated, shooting high. And usually it tends to be in the wake and the recovery. So he did the procedure, everything is fine. And by the way he goes back, his blood is shooting up and something, boom.
Yeah.
Which is annoying. But yeah, just try to, and again, I don't recall this is happening, that. But I tend to say something that, but this is how we try to deal with it. And again, you'll end up taking patient to theater again, but that's not the end of the world. And this is surgery. Shit can happen. PK planning, I think we talked about this. I wouldn't add anything more here. This is the flexible cystoscopy look. So building up confidence is important. Don't give a patient a shock. But I think what I mean here by building up confidence, don't go to the difficult ones first if you're starting at treatment. I think you're all expert now, and you know which one need to be done. And don't go wild as well. So don't put lots of injections. Don't go to extremes. Don't start with the difficult cases first. I mean, try to avoid difficult cases as much as possible. We talked about the exit. So the top one is the cold flow. The bottom one is the exit. And I used to go and adjust it slightly to make sure it is beyond the sphincter. Can you see going back with my resume scope and pushing the exit?
Not on this into this.
Yeah.
I think that's
I put it under vision, and despite this, I stopped using it because it's the bleeding when it clots, the patient in the recovery, and it's a small clot. Yeah, and usually when you introduce it, this is when you get the bleeding. So I decided when I put it, it has to be very, very straightforward, clean. You know, when you inject the resume and it's completely clean and no bleeding at all, you can put one. But the top one is actually, but we're using the top one, which is the cold flow much more. And this is the part that stays in, and this part goes out. And you fill the balloon. So you put it like a normal catheter, fill the balloon, pull it, and leave it. Patient goes to recovery, connect with urine bag, urine is clear, you're happy, everything is fine. Then you basically remove this string and just pull this one, and this one will stay in, connected with this. Then you do a tie, and cut, so this goes away, and from the penis will be only a small part of this. When the patient comes back a week later, so he should be peeing now normally. There's no, so this is what we call it bagless catheter. There's no bag. So the patient pee normally. So the problems with one of the disadvantages that people find post-resume, especially that you leave the catheter for a week or two, and the bag problem issues, things like this. But if you put one of these eggs in your or cold flow, the patient pees normally from day 0. So first day it goes on with peeing normally, and when he comes back a week later or something, you have ties here to block this. Cut below, empty the balloon, and just put it. So this is the kind of one of the things that we started to use more to avoid catheters and the problem with catheters. Post-operative medications, a lot of people now are thinking about avoiding giving antibiotics. I still give antibiotics, but I know that rather than giving a week, many urologists have done only 3 days, and few stop giving antibiotics completely. Again, it's an inflammatory process, so I'll argue that this may be not the best thing. I think I showed you a video in my phone earlier about the sharing catheter, and this is when we do resume complete at the local. So this is, you put the catheter in, fill the balloon, pull it back. This is all hiding here. And then when you are in a certain position, so when you pull the prostate, you pull the balloon, this area is in the prostate. And then you start injecting here, 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 here. So again, the same 4 quadrants. Now it's the prostate at 7, 11, 1, and 5 or 4. This is a plastic needle, so it's not very sharp actually. So it's one of these plastic firm kind of needles. And it's one of the very, very effective ways of doing local prostate block without doing transrectal or transperineal, because both of them are very uncomfortable. So we started doing this in the last few months. We've done, I think, maybe something like 10 or 15 cases until now. And the outcomes is quite very promising, with patients receiving it as a very suitable
Is
technique.
it easy to take this?
Sorry?
Is it easy to rotate?
Yeah, very easy. Did I show you a picture? Huh? No, it's a kind of simulation. So one of these, so it's and the way you hold it. Did I show you the pictures? I think I was supposed to download it on the computer. It's taking a bit of time to download, but it's fine. But yes, it is easy to. It's very easy to use. Any questions? Yes.
Post-operatively, after you've done a resectomy, would you recommend putting the patients on alpha blockers for a small period of
Yes.
time?
Yeah. I'll keep that chocolate maybe for 3 to 4 weeks at least. So you know that you always give them a recovery period between 4 to 8 weeks. So this is when I keep them on alpha blockers. Yeah, definitely.
Usually our protocol for the resume, just I like to share it with you because there is nothing written, so I'd like to just share the experience. Usually what I do after the resume, I keep the catheters, each 10 grams,
Yes.
1 day.
Yes.
And usually I keep the alpha blocker or 5-alpha reductase for 4 to 6 weeks.
Yes.
What do you think? Can I add something more?
No. The only thing is, do you give them finasteride?
It depends sometimes,
Okay.
because usually what I do, if the patient has a normal PSA and the prostate more than 50 grams, usually I start finasteride.
Yeah, I get where you're coming from. I can see no problem in keeping them at 4 to 6 weeks like you're doing. So I'll completely approve this. Yes, and the catheter. The only thing with the catheter is with more severe symptom, with larger prostate, I tend to leave it long. So the bigger the prostate, the longer.
Yes.
So if you talk about even if it's if you take this theory and you say that's it's a 90-gram prostate,
9 days.
I would actually do 2 weeks.
Yes.
The thing with the 5-alpha reductase, it will not act rapidly, so you'll not expect that it will.
Sure. This is 5-alpha reductase will work 6 months. I know, but the patient, for example, is under 5-alpha reductase since months or years.
Yeah.
So I just keep it. I keep the alpha reductase and the 5-alpha blocker.
No, I think this is very, very easy.
How could you preserve ejaculatory function?
Very good.
And final message is remove prostate. How could you do that?
That would take
How could you preserve
And I was going to tell you how you can preserve.
ejaculatory
second part.
function?
Huh?
Ejaculation
I,
is you assumed to be good
Yes.
for preserving ejaculation.
yes.
And the final message is the same as TRB and HOLIC, which is removal of prostatic tissue.
It's not exactly moved, it's shrinking. Okay. And also, so we have to agree. First of all, what is the mechanism of retrograde ejaculation? So originally it was retrograde ejaculation when the theory was cutting the blood fibers will lose the shutting mechanism and it will be weaker. Until Mizrahi did a very nice thing. He did a TRB and he put a trust machine in the bottom of the patient and asked him to masturbate. Looked at that and it's not the theory.
Yes.
Completely. So this theory is kind of completely destroyed. It was a very interesting thing when he had this study. And it's not a study, I think he did it in 1, 2 or 3 patients. But it was a very interesting thing. I can't show you my phone. Anyhow, so I think the current theory is the area of the vertical down. So that's why everybody is doing the TURP preserving ejaculation, the green light preserving ejaculation. When you avoid this area of the ejaculatory ducts, exactly, and you have to make sure it's not only the collicular muscle thing or the vertebral lead, but also slightly outside, because you don't want to go deep, because this will strain the ejaculatory duct, not opening it. So this is the main thing. That's why if you're going to do a resume, and do I have a video? If you do a resume, you have to understand the patient priorities. So if the patient priorities is to avoid, is to preserve ejaculation, then you need to make sure that your injections are high and slightly away. So the distal injection high and slightly away from the brain. If the patient, this is not of his priorities, and you know that he has a very weak flow or retention, then I don't mind that you go slightly to this area, which will increase the risk of venous ejaculation. The risk of ejaculatory dysfunction, rather than ejaculation, is maybe above the written thing of 5 to 6%. I think it's at least 10%. But it is not only this. It's not only ejaculatory and ejaculation. It's also reduced amount of ejaculation. So it comes in more than one format. But the patient needs to understand this. Because we had one patient who interestingly didn't have resume but had hypho. And we warned him about ejaculatory problem. But for him it was not clear. And he thought it would be fine. And interestingly, he still have ejaculation, but guess what? It's a water ejaculation. So there's a change in the nature of ejaculation. And he's making the highest fuss. I lost my sex life. Well, he still have ejaculation. But the nature of ejaculation, he doesn't like it. And he tell me, where is the old days? I get the ejaculation, I take my cigarette, I'm enjoying life. You destroyed my life. So these patients, you have to counsel them because you end up with troubles that you don't need. You don't need this kind of troubles. And there's some crazy patient that can make. I mean, it's not crazy, but from his point of view, I think he is. Yes, but it's from his point of view, this is his life.
Actually, I have one patient with an ejaculation. The reason for this, I can't remember why, because I was let it be close to the video.
So if the patient is very keen, and you have to tell him that there is a chance, but we can decrease it, but this may be on the expenses that we don't touch the apical loop and you may have some residual symptoms. So if he tell you, I'm very, very keen on ejaculation, okay, try to avoid this area, but still it's not a 0%. So what is the operation that is a 0%?
No operation.
No operation.
No, there is. No, you left. You left. ITIN until now, yes, but I think it will change with time because the way ITIN is done, it's still playing in this area. And again, it's not. But on the other side, the amount of ITIN that we removed is a lot. Let me show you something, by the way. It's another nice video. We didn't do this talk. I don't think we had the time. But anyhow, in this talk, there was one of these. So lots of people ask this question: would you do resume after you left? And the answer is yes. I think we have a series of maybe at least 10 patients who have resumed post you left. But the best way to deal with failure post you left, in my vision, is actually green light. And the reason for this is you do 2 in 1. If you do resume, when you go back, most of these patients, when you go back, you don't see the left needles at all. And then you do a resume, and then you have to warn the patient that most likely you need to come back and take it. With the green light, you do a cavitating surgery with immediate improvement in the symptoms, and at the same time, you can cut the needle safely with the laser. Because if you do TURP, although it can do the trick, but most likely will destroy one or two loops. Because it can destroy them. That's why green light is the best. So I thought it was the last one.
You just mentioned that you can do a resume procedure just under interstitial or xylem.
Yes. Yeah. In selected patients. Not in everyone.
Okay.
But the shelling catheter is probably the best way we found it until now.
Because that's not available. And suppose you don't have that available, then just remains to gel.
No, because we just started using it recently. We didn't have it before. So we tried before everything. We did the transectal, we did the transperineal, and then we found that the best thing is to just do the patient under sedation if he wants to have, not to have any anesthetic. But we were under pressure as well to move patients outside of the theaters. So we also done underlimbocane, and we found that a lot of, not a lot, we didn't do massive number, but we done few. And the patient, if they tolerate a scope, they tolerate a procedure. Remember, it's just a 9 second.
But
So
they tolerate the steel.
I mean, if they tolerate the scope, then the annoying part of the scope, and then imagine it's like a sting for 9 seconds. How cannot? I mean, if you tolerate the scope inside the pedis, then you will tolerate the sting. And this is what I found it. Why do we need all of this? And I have to be honest. I mean, it's to do a proper study. So I was just doing the shelling thing. I think, you know something, guys, the best thing to test your shelling is to inject one side only and do the big scope for both sides. But it's slightly unfair. And it's kind of, you have a catheter this side, you know that you're injecting local anesthetic. But I thought about it and I thought, okay, we can do the proper studies and this will give us actually an answer. Are these things working? Or we just imagine? Because you actually have a proper randomized controlled double-blind everything study by just simply injecting one side and not the other side and not telling the patient which side you injected, and then you ask him which side was more painful. Some of them will tell you they're both shit, and some of them are both painful. So it's really interesting. So I was actually looking about this with colleagues, and we may do it, but I think to do it we have to have a proper protocol and have ethics approval. That's why we're not doing it. Okay, so we have more talks. If you feel that you're fed up and you want to do some play in the back, but I think you all.
Most of us
Huh? مفيش حركة.
ممكن.
Yeah, it's up to you guys. Do you want to just finish this one, the challenges, and then you can do some okay. Fine. I mean, as I said, the challenges in the resume is mainly that it doesn't work. But there's few things that I'm sure that once you start doing few of them, you will learn it by yourself. But it's always nice to flags. So the main challenge, as I said, that it doesn't work. That there's a percentage of people who do resume, they come back and say it didn't work, and all you need to do to avoid big problems that you tell this patient, the counselor, that there is a very small chance that it's not the right treatment for you, but it's a very straightforward treatment. It's very likely that it will work, and as any treatment in life, it may not work, but this is the worst case scenario, no harm done. It may take longer time than expected to work, so you have to wait at least 2 to 3 months before you decide to go and have a second look. Unless the patient has severe irritative symptoms at 6 weeks, and this is when I tend to know that there is a sloughed area or something that is not right. And this will be at a sloughed area, a part of the process they didn't have treatment at all, and playing like a ball valve. And I will show you something like this now. This can be quite disappointing for the patient and the surgeon, but it's very unlikely to cause harm, as I said. So make sure that the patient is well counseled. I think we talked about this thoroughly already. Positioning is very important. You don't want to put the patient in a position to make it difficult for you. So don't put the legs very high up, otherwise you'll make the bladder quite high and you'll have to go above this cliff. So I always tend to put it in the relaxed Lloyd Davis position. You know what is Lloyd Davis and what's lithotomy, right? You know the difference. Lithotomy when the leg is very high up, Lloyd Davis when the legs are relaxed down, so that you're avoiding the high curve in the youth. If you have large median lobe, there's two ways to bypass this. Either to come from one side of the middle lobe to reach your way and then jump above, or sit tight for a while, keep filling the bladder, and when the bladder is full, it will push it down for you. Or you start your treatment from distal to proximal. So there is many ways to do this. And again, just press slightly more down, and then you end up in the right place in 99% of times. Make sure that the handpiece is working. Don't forget to do the pre-treatment cycle. This is the small things that we can forget sometimes, and it can make the procedure a little bit wrong, and you're injecting the wrong thing. Check the draining tube is closed, because sometimes you remember the draining tube, if it's open, there will something go fault and it will not work. Drop your hand down. It's very easy to do a flap. I remember I was doing a live case and in the resume, and it's the first and the only one that I raised the flap. So I was we were doing a workshop in our hospital, and we have lots of attendee down, and I was just doing a resume, just done, and then suddenly I raised the flap just before the sphincter. I mean, luckily I managed to go back and go above it and go to the right place. But it's not difficult to raise the flap because of the scope is straight, not pivot like the normal scope. Is this a leak? No, it's not. When you inject, you may get this desiccation, or the fibers can tear apart. This usually happens in a small prostate. And you kind of think it's probably a high bladder leg, and my injection was lower than it should have been. So we have to be sure that our injection is slightly higher rather than lower. So always remember the injection is not in the middle, it's slightly higher. If you go in the middle or low down, you end up with grooves down. And this can, when we've seen few patients who had subtrigonal groove, which can be challenging in the future if the patient can get in trouble with putting a catheter. Avoid falls, and we talked about start from distal to proximal. Left and right, when you are treating the left patient hand side, use your right hand. When you're using this side, use your left hand, so you can avoid conflicts with all that attachment. And the problem with this, that if you insist to do like this, and you take some of these things with you, your vision will not be in the right place. So you're basically looking at the prostate angle, and you end up putting the injection on the wrong side. So I always insist that change hands, so you avoid the problem. Or at least if you do this, because some people are really minded that if you use the non-dominant hand, it will go wrong. And actually, this is a very simple procedure. It shouldn't be a problem. Bleeding, if we get bleeding, it can be annoying. But again, you can see that you can put an injection and the vision can be poor. And we know once you get bleeding that you may not be very unlikely to see that. You can see that the vision is bad. And the problem with this handle, that the wash is very, very minimal. And what I would advise usually, find your landmarks, come closer to the tissue, finish your procedure quickly, and go away. Don't start looking, where is the tissue? No, just go to the bladder, then come closer to the tissue, start counting, go 1, 2, go, look, start, make sure that you have. And once you start injecting, by the way, it will stop. Remember that this is heat. So whatever is bleeding will stop. and I always say steamboats and kind of don't stop. To avoid bleeding, make sure that when you're going inside, don't scratch the tissue. Be in the middle. Avoid touching the tissues. You can use the turbo flush, but remember, if you use the turbo flush, it's very easy to deploy the needle. Now, we had this before. The turbo flush, when you do double clicks, double gentle clicks, the problem that sometimes we do double non-gentle clicks and you end up deploy bleeding in a complete wrong place. And I've seen this a couple of times in the listen. It will not cause a problem, but it will cause more bleeding. So it can be quite annoying. Drain the bladder and work with the landmarks. So, you know, sometimes you put the needle and you find leakage of vapor. And this means that the designated amount of vapor or steam is not delivered within the right space. So what you need to do is to lock the hole by moving slightly backward or inward, or push slightly more. So, and to avoid this, make sure that you do gentle pressure on the tissue before you deploy the needle, and then you're very unlikely to have this problem. But worst case scenario, just continue the treatment, and most likely you will take most of the steam away. It should be fine, and should be fine. Middle loop is always a troublesome thing, and this is one of the cases where the patient had this view, and we became classificative symptoms, and you can see now that this patient actually prostate completely disappeared, but the middle loop was completely necrotic, and all we need to do, severe irritative symptom, a 6 result, this is not normal, and I went inside and I found that this is the middle loop completely sloughed and attached. You go push it, wash it out without the catheter, patient being very fine, very happy. So this can happen. And the patient with the middle loop, sometimes this one is the problem, that the whole middle loop is sloughed. This was another interesting case. Do you know this one? Now this is actually, this one. Can you see half of the middle lobe have been treated and the other half is still there? And you can see that it necrotized this part and did fall to the bladder. And either we give it another injection, or sometimes much easier to give it one swipe with the resectoscope and problem solved. Because this prostate was not like this before. It was much bigger. So the main prostate of the lateral muscle have shrunken, and you're just ending up with this. So whatever, sometimes it's not a bad idea just to take one swipe with a resectoscope, or like this one, you have one swipe. Also, you can have on the left side here, can you see this? Subtriangular recess. And what we've done is just we open the bladder neck here to make it all one cavity. I'm not sure what was the problem with the patient while we did this, but definitely he was not feeling well. I think the bladder neck here was still high, so it was causing a blockage. This was an interesting one. This is one of my patients who I did this with a very big middle loop. And actually the prostate was quite sizable. He came back, everything all the lateral loops have completely disappeared, and I had this finger, you see with the middle loop. And I vaporized it with a vapor float, and this was the end of the procedure. So basically, he had a very good cavity in general, but all I had to do was just vaporize this with 2 minutes, and the patient came out with that catheter was absolutely happy. Sometimes you get some kind of bubble effect, and then with this picture, and again, the problem is with the bladder neck still high. And when you go back into this patient, you may warn them that you may need to do a minor procedure like opening the bladder neck or one cut here or there. And it doesn't require more than that. How common this is? Really not common. Very, very. I mean, these are the patients reported over years and years. So these are not common scenarios. This is a rarity. I think we were quoting 1 to 2% that you need to come back and do something early on, I think in the first 3 to 4 weeks. These are things that I have never seen it happening, but we know that sometimes it was reported that you don't retract the needle, and all you need to do is just remove the clip in the back, and then this needle will come back quite easy. This is just a U-lift clip. I don't know why I put it. And this is a standard case for Zoom, which I will return. Actually, this is the U-lift. So you can see the U-lift, and this is when I done the V-lift. Any questions?
Just a suggestion, because when we were also doing a lot of breathing cases, I think that they need to devise a small mechanism wherein you can only have the flow of water without having the deployment of the needle, like a lock or a switch kind of a thing. Because many times it so happens when you're introducing the scope, and you want to have a turbo flush as you're introducing the scope, there is a probability you might deploy the needle even in the urethra or before the process.
Yeah.
So I think we need to devise a small mechanism.
I get your point. It shouldn't be the same,
Exactly.
same switch. Yeah. No, I agree. We can discuss this in an expert meeting. There's usually expert meeting that discuss things like this.
Okay.
And there's many suggestions that was taken about things like this. But again, it's a big investment for the company to modify the shape of that. And again, I tend to say don't use it. I would suggest this turbo action doesn't help a lot. So I don't need to really use it. Any questions? It's probably more of the interprostatic length that you're looking at, and every two field divisions you need to put an injection. But if you have a high prostate, you may actually have a road at the top and a road at the bottom, or like a zigzag shape. I always call it zigzag shape. So it's not only the size, it's the shape of the prostate, and also the middle loop. And in the middle loop, you have to be careful. Try not to put massive number in the middle. Maybe 1, maximum 2 injections. If you put more than this means that you're really dealing with a very big middle loop, and you have to warn the patient that post-operatively there may be a slough, maybe problem, maybe. So you have to kind of warn him that this was a very sizable loop. Hopefully it will be fine, but we may need to come and have a second result.
Maybe injection. How much is the ball between this plasma line? 1 centimeter.
Around 2 centimeters. Yeah, and not sloughed. So the whole idea is, the whole idea that you are killing the hyperplastic cells, the BPH hyperplastic cells, by the steam going between the cells in the interstitium and causing this mechanism of vapor condensation. But theoretically, the epithelium should be intact. So you actually do a puncture. If you go early, you'll find like a crater, like فروة المكان كده. But most of the epithelium will be there. And this is the difference between this technology and the old tuna, the needle ablation. They actually all the epithelium and the tissue stuff. This will be quite late. This is wet heat. And wet heat is a gentle way of killing the cell.
At the beginning, you were saying that super advanced prostate might limit the water layer. I'm not a doctor. Is there a way to identify whether this tissue is?
Also, it's our theory. We cannot prove it. And one of the things we talked about is doing one of these, the elastic ultrasound, just to see the density of the tissues. I don't know a single technique that we can predict it. And I would say, warn the patient that this is a possibility, and we know that there is a group of patients would need a retreatment, either because they have a big prostate or they have a poor response to the Zoom. It's a theory, we don't have a proof. And I don't think we can predict it. Are we tired? There is more talks. What do you prefer? يعني we go through this quickly الصراحة لأن هو البايلوت studies يعني was very descriptive that the improvement in the IPSS score, the KUA16, this was all absolutely fine, but these were all well-chosen patients. So actually, the first studies, there was no middle loop. Interestingly, the patient with the middle loop, when it's well treated, actually the flow improved more. So this was all the early studies, 195 patient and 129, the pivot 1, 2. So these are kind of all early days, effective. But when you look at the improvement, the QMAX is probably not massively improved when compared with the new studies. And I think the QMAX improved to 9.9 from 5.3, things like this, plus or minus 2.3. IPSS. So basically, they were very conservative in the early studies. When people started to move on and even the number of treatments, you can see it's only 4.5 plus or minus 1.8. And now, because people are going to bigger sizes, to more treatments likely, be less conservative, for flow improvement, the flow have been better. Even the reduction in the prostate volume can أقل في الأول. I think in the first description around 25-27%. Now it's approaching 35%. Management pain, he used to do oral sedation, post-block IV sedation. So these were the American studies, and the Americans used to do all these patients in the office. So that's why they were all depending on the local anesthetic. But compared to IPSS, this is the pivot 2, but I think this is patient who started with low IPSS compared to patient who started with the high IPSS and the same improvement. So there's no massive difference. The QMAX, as you can see, there is improvement, but again, very stable, steady improvement up to 2 years, and the local studies show the same thing. No effect on the IF, erection is there for fetal ejaculation. Dysfunction is maybe 5 to 10% more than quality of life improved, PSA stable. Did anybody notice change in the PSA post-resume? We've started to notice that there is a decline for the PSA to come up slightly after the resume, and we've done very few of them had MRI, showing inflammation. So there's a tendency of increased PSA rather than decreased. The 5-year data, again, showing the same thing, stable, steady results. And as you can see, the need for retreatment is only 4.4% at 5 years. This didn't change. I think it's more than that now. As I said earlier, I think it's maybe 6 or 7% beyond 5 years. But this is compared to ULEFT. It's not, I mean, ULEFT retreatment is not 13.6. I think more if you speak to ULEFT people, it's at least 30%. So these figures also are changing in time. Forget about the TMT and tuna, these are very old things that nobody's reporting them now, so very unreliable to compare. I don't think it's fair to compare to them. Symptomatic relief, although that we said that the retreatment rate is 4.4%, but there is an additional 5% who need medical treatment. And I think that this group of patients have persistent, not obstructive, but overactive bladder symptoms who require anticholinergics or beta-1 So the key takeaways is good, durable treatment, outcomes is really favorable, and you can see here that the flow massively improved. And we can see that many of our patients have this response, not everyone. The expectation that it is 50% improvement or 60 or 70, but sometimes the double and triple, you can see this patient. This is one of our publications. 2 years ago, we talked about our data from the UK, and it definitely resembling the original data, but even a bit better. And this was a 500 patient data between 2017 and 2020. And we treated was exactly the same, 4.6. But we also looked at the patient who had urine retention. Why did we look at this patient? Because it's 25-30% of patients coming to your clinic are actually coming with urine retention. So we cannot really exclude them from the treatment, especially the younger group who will maintain sex life ejaculation, or the older group who will not be able to have a standard treatment or anesthesia. And we looked at maybe 42 patients, 13 minimum long-term catheter, 12 implemented self-catheterization, average age 70, positive volume 61, bigger than average in other studies, and half of them had GE and half had local sedation. Average of treatment is much more 9, because these patients with retention, we tend to be slightly more generous in our treatment, and also because they have a larger positive volume and average. And the median, because a lot of them had median loop at 28, so more than half had median loop, and the average number was 2 injection per median. So, what did we, in the normal population, 92% of patients had a successful first trial of the catheter. In the patient with urine retention, 63% only. Having said that, you'll be surprised that this is almost the same percentage for a successful trial of the catheter after TRP in the chronic retention patient. So it's not far away from TRP results. And you have to be patient. Give them a second trial of the catheter and a third trial of the catheter, and we found that up to the 4th trial, a lot of patients will still succeed. So we give them up to 3 or 4 trials. Don't rush into another treatment, because there is an additional 5, 10, 23% that will have a successful. So you will end up maybe with nearly 80% of patients who will not need any other procedure or more catheterization. So don't just use hope from the first catheter, from the first time of the catheter, and give them a second and a third chance, each time at least 2 weeks apart, if not 3 or 4 weeks apart. I have to say that 50% of patients we didn't know was happening with them because they're coming from remote areas. So we hope that some of them also have better outcomes and managed to have a successful trial of the catheters. Flow rate improved, IPSS improved as expected, and summary, as you can see, that we have 80% managed trial with the catheter, good improvement in this group of patients. So I have no reservation to say that we can treat patients with this who have or presented with urine retention. We also looked at the large positive volumes, and in our so we divided into 2 groups. In these 475 patients, group less than 80, group more than 80. And again, the treatment is exactly the same, but interestingly, the bigger the prostate, the better the improvement in the flow rate, the better, and this is exactly the same improvement in IPSS. And the reduction in the prostate volume was better than the bigger group. So 32% reduction of bigger prostate volume compared to 29% reduction in the smaller group, which is less than 80. Mahmalji is one of our colleagues in the north, and he also had similar outcomes for a similar group of patients. So he did a similar studies, and he agrees with what we've done. So these are 2 studies from the UK. I think this is probably the kind of evidence we need to look at. Evidence to say that it works, evidence to say that it reduces the evidence to say that it is feasible, evidence to say that we can use education retention with a sensible approach, in the larger hospital volume with a sensible approach. So these are not valid indications, but it is a relative indication, as we can say. Do we have any questions? Shall we call it a day? Looks like you got here. And just a few people started to speak about me. But I mean, you're welcome to, I'm happy to guide you in any of the in the simulator in the back. If you have any question on the machine itself, the handle, things like this, I'm more than happy to have a play with you.
دكتور علي صراحة great يعني great discussions, open discussions. I have only questions about Eurolift. What is your experience? Because honestly, I have a small experience when I trained outside, but it's not allowed here in Kuwait because
I agree.
it's not allowed in the.
It should be allowed. No.
So what do you think about Eurolift?
So I don't have a direct experience with Eurolift because I kind of seen how it was done, and I didn't like the technology itself. I found it a little bit messy, and the theory of squeezing the prostate doesn't match my thinking. Putting a needle inside something tissue that is tissue. Yeah, I mean some patients had benefit, but it didn't make sense to me. So I didn't do any case, but I was working in 2 centers who was doing a lot of these cases. And but what I've done, I removed a lot of them. So that's why I know that they're not perfect. And I'll tell you also what is my take on it, is prostate cancer. It doesn't produce prostate cancer, but it will affect your diagnostic ability in the future. And we know that we're depending all now on the MRI as even a screening test. I mean, the recent publication or study done by UCL is saying it shouldn't be a diagnostic, it should be a screening test. So if you say that you have someone who came in his 40s and he's keen to do something to avoid sex problems, fertility problems, and you offer him a Eurolift at the age of 49 or 52, you're almost certain that this guy, because of the Eurolift itself and the inflammation, will come few years later with a high PSA for most likely non-cancerous cause, but he will not be able to thoroughly look at this prostate, and he will be ending having unnecessary prostate biopsies or a non-targeted biopsy, which is even worse. And this is kind of when I kind of counsel my patient, and if some of them coming and telling me I want to have Eurolift, that's absolutely fine. I'll send to my colleague, but he may not mention this. and this is the problem that it's unfair not to explain everything about the procedure because you know that this is a potential. I'll give you another example. Oncologists, they will mention to patient possible risk of other cancer in the future. How much this will take out of their discussions? But a lot of them will not even mention it. And if they are fair, it will take 1%. But did they mention what kind of cancer these patients come with? What kind of problem they come with? And who's facing this problem? It's not them. That's why they don't care. They don't see it. We see it. I have usually at least 1 to 2 patients in my work on the ward out, seeing them post 7, 8 years, 10 years, because people live longer now. Post-radiotherapy bladder tumors, and I don't know about that. I know about and it's horrible, and they come with also bleeding because of other problems. So these things, and I'm not saying radiotherapy is wrong, but I think we have to also if there's an option of prostatectomy and radiotherapy, then if you want to talk about the side, you can't say that radiotherapy you don't need to have anesthesia. You're not going to have incontinence. You come visits like a scan and go back for a few weeks and you'll be cured, and this is true. But if you at age of 61, you almost certain you will come back at the age of 80 with problems that we will not be able to treat. And people live that long and longer. And you know that they come with in and out intractable hematuria, this is if he's lucky, if it's not tumor. And the same applied to the, and that's why it's a kind of the same concept that, yeah, you have to be very, very frank in your discussion and explain what is it all like. That's why I kind of not very enthusiastic about Eurolift, but at the same time, for a young patient who have no appetite to accept ejaculatory problem, then this is what we have for you, but you also have to understand the consequences. I hope this answers your
You
questions.
mentioned that you've seen post-freezer patients, the PSA goes down.
Up. Yeah, I tend to see a few of them fluctuate with their when they're PSA and I offer them MRI and tend to find the usual 3/5. ها؟ حد عنده أسئلة ثانية؟ حد عايز يلعب ورا؟ هاتش يلعب جيب الأجهزة دي على الفاضي حد يكمل